It was a good, memorable time we spent, ma'am.
अर्चना तुम्हारा वीडियो ऑन करो ना, कहाँ गई? दिख नहीं रही अर्चना, कहाँ गई? रंजीत, उनको कोई प्रॉब्लम?
Ma'am, we are live on YouTube. So I welcome you all. This is Ranjit Sahu, Marketing Head with Waterbush, welcomes you all to Indo International Web Series 4 in association with RCOG India Liaison Group presents live webinar on abnormal uterine bleeding. With this, I hand over the session to the esteemed delegates, ma'am, to take it forward. Ma'am, over to you. Ma'am,
yeah. Thank you, Ranjit. I hope my screen is visible.
Yes.
Yes, ma'am.
Okay, right. So welcome to this Indo International Web Series 4. And we have the conveners for this webinar, which we are doing in an association with the RCOG India Liaison Group. And this is the fourth webinar in line, and every month this is the brainchild of our convener, Dr. Lakshmi Srikhande, who has been instrumental in putting the two worlds together, the India and abroad UK. We are liaising together for such wonderful, wonderful webinars. And thank you, the international faculties, for giving us this opportunity to listen to you, to be interactive with you, and to learn from you. Thank you so much. And I would also like to welcome here our international coordinator, Dr. Jyotsna Pundir, who is accredited FICOP RCOG accredited subspecialist in infertility and assisted conception. And because of some emergency, I think, I'm so sorry, she would not be able to join us. So we would be missing Dr. Jyotsna here. And our another international convener is Dr. Archana today. So welcome, Dr. Archana. Dr. Archana is a consultant in the University Hospitals of Derby and Burton, UK. And we are lucky to have you here as our convener. And I would like you to speak a few words as the opening remarks.
Yeah, Archana, your opening remarks are welcome. Jyoti, slide share बंद कर दो.
Thank you very much. It's an honor to be a part of this group, and it's a good, it's a good forum where we can interact, and I'm hoping to really enjoy the session today, and hopefully we'll be able to share some of the practice in the UK with you guys back home. So thank you so much for having me, and I've got with me Dr. Kulkarni as well, who's a very experienced person in adolescent gynecology. So I think we'd be able to share our knowledge with you guys, and hope it's going to be useful for you. Thank you.
Thank you so much. Thank you, Dr. Archana. And we would be listening to you in the talks as well, and in the moderation. And here I again welcome our national coordinator now, Dr. Sushma Verma, who's the director of the Savodaya Hospital, Raipur. So I give over to our national coordinator to take it over from here, Dr. Sushma Verma.
Thank you, ma'am. First of all, I want to thank Lakshmi ma'am for giving me the opportunity to introduce our esteemed chairpersons. And firstly, I want to introduce Vijay Lakshmi Sheshadri ma'am. She is the Senior Consultant Obs and Gynae, Sundaram Medical College, Chennai, and she is the President of OGSSI. She is the Executive Committee member of Tamil Nadu FOXI and Constitution Committee member of ISOPRAV. And her special area of interest are in high-risk obstetrics and midlife health. And secondly, I want to introduce Dr. Supriya Jaiswal ma'am. She is the Secretary of Patna Obs and Gynae Society, consultant of SM Hospital Patna. She is the executive member of ISAR Bihar chapter, and her special area of interest are in high-risk pregnancy and in preventive oncology. Welcome you, ma'am. And I request Supriya Jaiswal ma'am to introduce our speaker. Mukdha Kulkarni ma'am.
Thank you, Dr. Sushma. First, a very good evening to all of you. And at the outset, I would like to thank Dr. Lakshmi Srikhande, Madam, for giving me this opportunity to interact on this very nice forum, this platform to connect with all of you. Thank you very much. So it's a privilege to introduce Dr. Mukdha Kulkarni. She is a specialty doctor in reproductive medicine, leads teaching hospitals, NHS Trust. Area of interest is pediatric and adolescent gynecology, urgent fertility preservation, and outpatient hysteroscopy. So with these words, I hand over to Dr. Mukdha. Welcome. I welcome you. Thank you.
Thank you so much for the introduction, and the privilege is all mine to be involved in this group and to be able to share what we have learned here working in the UK. And of course, it's been a long time since I've worked in India, so it would be really interesting to sort of see the Indian perspective of how things are managed now. So I'll start sharing my screen. Okay.
Yeah.
So I work in Leeds Teaching Hospital, which is a tertiary referral center for adolescent and pediatric gynecology patients. And we get a lot of referrals from Yorkshire, which is where we are based, and the surrounding counties. And I've been involved with this service for more than 6 years. So I'm still a small fish, but I have a fair bit of experience in this field, especially in dealing with abnormal uterine bleeding. So, how do I go forward on this? Yeah. Okay, so adolescence is a very delicate time in a child's life, and they go through a lot of physical and psychological changes. And the onset of menstruation is a very important landmark or milestone during adolescence. And any menstrual disorders are naturally going to cause distress for the child and the parents or carers. It can often disrupt social activities. It can affect school attendance. It can affect the ability of the child, or it can affect the ability to participate in sports or dance or anything for that matter. Although it's very, very
Indo International Web Series RCOG की है ये voice तो है नहीं नोएडा वाला भी चल रहा नोएडा ऑब्स गाइनी वाला भी
Dr. Mala, I would request you to please mute yourself. Thank you. Thank you, ma'am.
Although it's very rare to find any serious pathology, it is often the first time that a lot of medical conditions may sort of resurface or manifest themselves. So what is abnormal uterine bleeding? It's any variance from normal menstruation. And this is usually based on 4 parameters, including frequency, regularity, duration, and the volume. And heavy menstrual bleeding is the commonest form of abnormal uterine bleeding. And we're going to talk about this a little bit more later. So what is heavy menstrual bleeding? So I think all of us have read in textbooks that anything more than 80 milliliters is classed as heavy menstrual bleeding, but it's very difficult to judge blood loss or to weigh blood loss. And there have been lots of various systems that have been used in the past. But NICE, which stands for National Institute of Clinical Excellence, has defined heavy menstrual bleeding as any excessive menstrual loss that will interfere with the patient's physical, social, emotional, and material well-being, and that could be irrespective of the actual amount of bleeding. Okay. And any intervention that we do or any management should be aimed to improve the quality of life of the patient rather than actually focusing on the blood loss. So abnormal uterine bleeding can be classified as chronic or acute. So chronic is anything that is more than 6 months. Acute is any abnormal bleeding that is severe enough to require immediate medical intervention. And I'm going to share a flow chart later on that will sort of discuss how you manage acute abnormal uterine bleeding. So this is my paper that we published in 2017, and it is just to highlight the need for education in the primary health sector and gynecologists about the causes of abnormal uterine bleeding and how they are managed, because as I explained, ours is a tertiary center and we see a lot of patients. And what we found that almost about 10% of the referrals that we got were for simple conditions like abnormal uterine bleeding, which had not had any primary intervention. And that is what explains or emphasizes the need for education and for establishment of clear guidelines. So a lot of terminologies have been used to describe abnormal uterine bleeding, and most of these are sort of Greek and Latin, and there's no universal consensus as to how to use them, and there's a lot of disparity as to how they're used. So FIGO proposed to get rid of all these terminologies, and they've introduced a very simple classification system. System 1 is based on what is normal and what is abnormal, and system 2 is based on the actual causes of abnormal uterine bleeding. So this is FIGO abnormal uterine bleeding system 1, and so it's based on parameters like frequency, duration, regularity, and the volume of bleeding. So a 24 to a 38-day cycle is considered to be normal, and a variation of 7 to 9 days between the shortest and the longest cycle is considered to be normal. So earlier on during life, between up to the age of 25, it's normal to have sort of a variation of up to 9 days. And again, towards the end of the reproductive years, from the age of 41 to the age of menopause, it's normal to have variation of up to sort of 9 days. But during maybe the age of 26 to around 40, we expect less variability, up to 7 days between menstrual cycles. Blood flow of less than 8 days is considered to be normal. And of course, more than 8 days bleeding is considered prolonged. The volume, interestingly, that is patient determined. Okay, so we can't calculate the actual volume of it. It's very, very difficult and practically very difficult to calculate the volume of blood loss. So it's up to the patient experience and what they think is light, normal, and heavy. And of course, you have intermenstrual bleeding and unscheduled bleeding for patients who are on any hormonal medication. The system 2 classification, that is based on clinical and imaging, that is ultrasound or MRI. And it's the causes for abnormal uterine bleeding are classified as structural. So something that you can classify based on ultrasound or histopathology. And the non-structural causes are more based on clinical assessment and laboratory diagnosis. In adolescent girls, structural problems are very rare, less than 2%, okay? And so I'm going to cover more about the non-structural aspects of abnormal uterine bleeding in my talk. And Archana will cover the structural causes, which are more likely to be present in the adult age group. So of the non-structural causes, ovulatory dysfunction is the commonest cause of abnormal uterine bleeding in adolescents. And a lot of times it can be managed by simple reassurance, and we can talk about this a little bit more. Okay, so the onset of menstruation occurs in the setting of a maturing hypothalamo-pituitary-ovarian axis. So I've just got this little diagram here. So there is poor regulation between the hormones of the hypothalamus, pituitary, and the ovaries, usually in the first couple of years after the onset of menarche. And this tends to improve over 2 to 3 years. And because there is poor regulation, there is usually a failure to produce a pre-ovulatory follicle, and therefore enough estrogen that will provide the positive feedback to the pituitary for an LH surge. And therefore there's a deficiency of the luteal phase, and this will result in irregular and heavy bleeding. So about 50% cycles in the first 2 years after menarche are likely to be anovulatory, but this does improve over a period of time. And in about 5 years after menarche, we expect about 25% of the cycles to be still anovulatory, but most girls will settle down to have periods between sort of 21 to 34 days. And after 5 years, it's quite likely that 20% will continue to have anovulatory cycles. So it's important to educate patients and parents about this when they first come to you in clinic, because obviously they will get alarmed about the irregularity, and mums often do not quite clearly remember how their periods were, and they always try to compare their daughters with themselves, saying that I never had this problem, but why is my daughter having irregular periods? And therefore it's very important to educate patients about this. And a lot of times simple sort of reassurance can help them to tide over the first 1 or 2 years after the menarche. It's important to remember other causes of anovulation though, like polycystic ovary syndrome, thyroid disorders, or hypogonadotropic hypogonadism when you're investigating somebody for abnormal uterine bleeding. Now, polycystic ovary syndrome is very difficult to diagnose in the adolescent age group. It's because if you consider the Rotterdam criteria, oligo-ovulation or infrequent cycles, as I said, can be attributed to the immature hypothalamo-pituitary axis. Often girls at this age will tend to have multifollicular ovaries, which is Rotterdam criteria too. So it's likely that if they present with signs of hyperandrogenism, they could fall in the polycystic ovary syndrome, but it's best to not diagnose PCOS till they have crossed sort of the 2-3 years after menarche, because it's because some of these criteria may be just due to the immaturity of the hypothalamic axis. Excuse about this. So the next important cause of abnormal uterine bleeding is coagulation disorders, and up to 36% of girls may present with coagulopathies, may present with abnormal or heavy menstrual bleeding. The commonest coagulopathy that we find in this age group is von Willebrand factor disease, and the prevalence could be as much as 28%. And this is something that should be kept in mind when you are investigating somebody with abnormal uterine bleeding. Of course, there could be other coagulopathies like any sort of coagulation factor deficiencies or hemophilia. And it's always important to manage these patients with the help of a hematologist because they are the experts. Remember that platelet dysfunction, which could be qualitative or quantitative. And there are some syndromes like Glanzmann's and Bernard-Sollier syndrome or immune thrombocytopenic purpura, which can be manifested for the first time when girls present to you with abnormal uterine bleeding. So it's important to ask for history of any nosebleeds, any easy bruising, any prolonged bleeding after any sort of minor wounds or dental procedures, any family history of easy bruising or nosebleeds. I think all of us have done that. We've underestimated how common STIs are in this age group, or sexually transmitted infections, because we often find the conversation very awkward when we are talking to patients and asking them about their sexual history, but it's very, very important. And often these girls come to you with their parent and they will find it very, very difficult to disclose any information. And it's important to have a dialogue with them in seclusion when you can and reassure them that all the information is going to be confidential. And I often tend to do that when I'm seeing a patient in the outpatient clinic and they've come with a mother who's doing most of the talking, and you know that she's not letting the child speak. I often take them out into a different room with the excuse that I want to do a height and weight or a blood pressure. And often take the opportunity to ask for sexual history, because it's very important to rule out sexually transmitted infections or PID, especially if they've tried all the first-line medication to control abnormal bleeding and they're not responding. And I was just sort of looking at whether there are any statistics as to how common it is that adolescents are sexually active. In the UK, it's predicted that about 38% adolescents will have had sexual intercourse till they are about sort of 15 to 16. So it's very, very common, and it's important to ask for sexual history. Any methods of contraception, any hormonal medication can be associated with irregular or unscheduled or breakthrough bleeding, and therefore it's important to ask if they are on this on this medication. And some causes are not classified in this. So I think I forgot to touch upon the Palm-Cohen classification, but I guess you got it from the FIGO AUV system too. That is how the structural and non-structural causes are classified. And Cohen stands for, as we've discussed, coagulopathies. O stands for ovulatory disorders. E is endometrial. I is iatrogenic, and N is not otherwise classified. That is something that cannot be put into this category. Okay, so management of these patients includes a thorough history taking. Okay, and I cannot stress this enough. And the aim of history taking and investigation should be aimed at identifying an underlying cause. And although you're trying to do this, often you can start your medical management before you get to the underlying cause. Okay. Because as we said, it's all about patients' quality of life. So when you see them in clinic, if they're really distressed by their periods, you can offer them medical management and can continue with your investigations side to side. It's important that they keep a menstrual diary, because often patients come to you with saying that they've got irregular periods, the periods are all over the place, but they have nothing to show you for an objective assessment. And therefore you cannot educate them as to what is normal and what is abnormal. And this is made really easy now with the help of there are lots of apps that are now available. And I think there's one that I've seen called a Flow app. There may be lots of others that can help you track your cycle. And most teenagers now have cell phones, and they're probably more technologically advanced than a lot of us. So they can use these apps, and that will really help you in telling them as to what's normal, what's abnormal, what to expect. So this is a little table saying what investigations you need for abnormal uterine bleeding, and it's all very self-explanatory. So in history, important to note age of menarche, what's the exact cycle duration, length, what is the amount of bleeding, what they think, is it heavy? Do they report any symptoms of anemia? Because that is one important symptom that should prompt you to offer them any treatment. Any symptoms pointing towards coagulation disorders, symptoms of hypothyroidism, any history of acute weight loss or weight gain, any symptoms that are pointing towards hyperandrogenism, thus the possibility of them falling in the polycystic ovary syndrome spectrum. And as I discussed, sexual history, very, very important. Examination, again, includes body mass index, signs of hyperandrogenism, and not everybody requires pelvic examination. But if you're suspecting, if they're sexually active, if you're suspecting sexually transmitted infections or PID, then there may be value in performing an examination and taking infection swabs or imaging if relevant, pelvic ultrasound scan. And again, this may be relevant if you're suspecting any uterine developmental anomalies, Mullerian abnormalities. It may be of value, but otherwise would not request any ultrasound scan for patients presenting to you with abnormal uterine bleeding, unless and until you've tried a lot of medication, tried first-line therapy, and it's not effective. So laboratory investigations, full blood count, ferritin, important to understand if the bleeding is causing anemia, and therefore will help you to manage that coagulation profile. So what I tend to request is a prothrombin time, partial thromboplastin time, and von Willebrand factor screen. This is what I request here. And then if there is any abnormality in the initial coagulation profile, then I would liaise with the hematologist. They don't really like for us to request a battery of investigations, because it may not be cost effective to to do a whole lot of investigations, but you can always take an input from the hematologist and then decide if any more investigations are required. Thyroid function tests, and as I said, genital swabs if you are suspecting sexually transmitted infections. Okay, so in terms of the management for abnormal uterine bleeding, there is very little research and studies that have been done for adolescent patients, and the efficacy of all the drugs. The evidence is more towards adult women, and it is just assumed that it will be equally effective for adolescents. So it's just, the evidence has just been extrapolated. And medical management is the mainstay of long-term treatment in adolescent age group. So I won't talk a lot about this, the non-pharmacological aspect, but of course, if you are suspecting anemia, then it's important to educate them about the diet, and of course, to maintain a healthy body weight, because extremes of body weight can be associated with abnormal uterine bleeding. So it's important to educate girls about that. So this is a flow chart describing management of acute heavy menstrual bleeding in adolescents. And of course, the first and foremost important thing is to check whether they're hemodynamically stable, and they need resuscitation for that, which includes your normal sort of ABCD assessment, and then volume expansion, iron therapy, consider blood transfusion, and liaise with the hematologist if you're suspecting any coagulation problems, or if you're expecting to give a massive blood transfusion, then it's important to liaise with the hematology team. Desmopressin has a role for bleeding disorders, and then the arrest of bleeding. First line therapy is usually antifibrinolytics like tranexamic acid combined with mephanamic acid, and this can be given IV. Okay, so we'll talk about tranexamic acid in the next slide. Second line treatment is high dose progestogens. Okay, these are first generation progesterones, norethistérone and medroxyprogesterone acetate, and are highly effective in control of bleeding. And you can give a dose of up to as high as 20 milligrams 3 times a day till bleeding settles. Third line is estrogen therapy, which, as far as I know, I've very, very rarely seen being used, because a lot of bleeding will be controlled with tranexamic acid and high dose progestogens. And a lot of NHS hospitals in the UK do not actually have IV estrogen available in their formulary. So it's very, very difficult to procure IV estrogen here. But if high dose progesterones are not effective, then you could prescribe high dose combined oral contraceptive pills. So you can start with a high estrogenic 30 micrograms estrogen dose of combined pill, and you can give it 3 times a day till bleeding stops, and gradually taper it down to twice a day, once a day, and then you can continue that for long term. So I'll talk about individual hormonal preparations in my next slide. So let's talk about tranexamic acid. So tranexamic acid is very, very effective in managing heavy menstrual bleeding, especially if periods are regular and it's all about blood flow. Okay, very, very effective. And it is licensed for use for over 1 year, and find a lot of reluctance in GPs prescribing this. And I don't know why, because it's present in the, it says in the BNF or the British National Formulary that it is licensed for use. And it has a role in both acute and chronic abnormal uterine bleeding. It's tolerated well by patients. They don't have to remember to take it every day like they have to do the pill. So it's a very good medication to use. The dose is 3 to 4 times a day, 1 gram, and it is licensed for use only up to 4 days at a time. Okay, starting from day 1 of the period till heavy flow, or 4 days, whichever is earlier. And for young patients, it's available in the form of a syrup as well, so very easy to give them. And as I said, that it has a role both in management of acute and long-term abnormal uterine bleeding, and it can also be given in bleeding disorders. So it is something that you can prescribe to your patient straight away at their first outpatient appointment, even though you are still investigating this patient. Okay, of course, it's important to make sure that you've ruled out any thromboembolic disease, any renal disease, and anybody in the close family has any risk of VT or anything like that, or any history of VT. So mephanamic acid is a non-steroidal drug, and it acts by inhibiting cyclooxygenase and reducing the prostaglandins in the endometrium, and also has a very good efficacy. So it can be given combined with the tranexamic acid and can reduce blood loss to, again, up to 50%. It can also be used for dysmenorrhea, okay, or painful periods. And it's recommended to start a day before the start of the period, and you can continue it throughout the bleeding lasts or as long as they need it for the pain. It's used often in young girls. It has to be used off license if at all required, okay, because the British National Formulary recommends use for only girls over 12 years of age. So I've just listed all the hormonal preparations that are available, and we'll sort of talk a little bit about each of them. Okay, I don't want to go into a lot of detail about them because we all know what these preparations are. I'm just going to highlight what their efficacy is in terms of management. So medroxyprogesterone acetate or norethistérone is often used as first line in the management of girls with abnormal uterine bleeding, although you can argue that combined hormonal contraception can also be an effective first-line agent, and this is what I tend to use most, combined hormonal contraception. There's a lot of reservation in parents using the contraceptives because, of course, they feel like, oh, it's a contraceptive, they don't want their girls to be seen with a contraceptive pill. So there's a lot of reservation from them, but again, it's educating the parents about how effective the pill may be, and they don't have to continue it lifelong. It's only to help the girls tide over the first 2 to 3 years when the hypothalamic axis is immature. So both the progestogens and the combined pill can be effective up to about 80%. Medroxyprogesterone acetate is my drug of choice because norethistérone can be associated with androgenic side effects like acne, hirsutism, and there's also reported to be a high risk of DVT with the use of long-term norethistérone. Combined hormonal contraception, again, lots can be prescribed in lots of ways: the oral pill, patch, ring, lots of different ways in which can be done, but the oral pill seems to be the most acceptable in the adolescent age group. And it can be prescribed in the traditional method, that is, they take it for they run a pack for 21 days, then they take a break, or it can be prescribed in the extended regime, so which means that they take the packs back to back for 3 months and then have a break every 3 months, or a flexible extended regime, that is, they just run packs back to back. And the risk with that is that they can experience breakthrough or unscheduled bleeding. And if that happens, we just suggest that they take a break for 7 days, allow a bleed, and then restart the packet. The advantage of taking the extended or the flexible extended regime is that, of course, because you reduce the frequency of bleeding, that will help you to treat and prevent further anemia, okay, and of course cause less distress to the patients. And of course, when these girls are going on a holiday, when they're going taking an exam, it's something that you can offer to them to avoid bleeding-free days during that time when they're taking their exams or they don't want a period. The progesterone-only pill, and the one that's commonly available in the UK, is the Desogestrel containing progesterone-only pill. And it can be effective in stopping periods in about 20%, but it's not as effective as the combined pill and the progesterones, especially in the abnormal bleeding that's associated with the immaturity of the hypothalamic axis. But it is something that can be offered or trialed for patients who have a contraindication to the combined pill, or for patients who are not responding to the pill. So it's an option, but won't be my drug of choice. Okay, I will only get to it if the high dose progestogens or the combined pill are not acceptable. The Levonorgestrel intrauterine system, again, very, very effective in control of heavy menstrual bleeding, and is an option for even adolescent girls, and it can be introduced anytime after menarche. The only difficulty is, of course, if the girl is not sexually active, then to be able to introduce it, she will require a general anesthetic. So each time when she has it put in or removed, she is going to require a procedure with a general anesthetic. In the UK, only the 52 milligrams IUS, that is the Mirena and the Levocert, they are licensed for use of heavy menstrual bleeding. The Kylena and the JDS, they are also available. They're smaller devices, and JDS is much smaller and it's much easy to introduce. So it is an option, but it's not licensed for the use of heavy menstrual bleeding. So the depomedroxyprogesterone acetate or the Depo-Provera or the NET-N, these are also good alternatives, especially if the patients are not responding to all your first line medication. The only risk is that there is a good percentage of girls who will report irregular bleeding within the first year, and about half of them therefore will decide to stop taking the Depo. Also, a lot of bone mineralization, or 90% of the bone mineralization, occurs under the age of 18 years. So therefore, it's very important to keep in mind the risk of osteoporosis in young girls, and it's important to review the need to continue the Depo-Provera every 2 years. You can also combine this with bone scans to make sure that it's safe to continue the Depo-Provera. GnRH analogs, last resort. Okay, if none of the other options are working, and again there's a risk of osteoporosis with long-term use, and therefore it's important to consider regular bone scans and add back HRT if that is the only option remaining, and if your patients need to be on it. So I'm going to touch a little bit about some special scenarios. So you may often encounter in your clinic that parents bring girls who have different medical conditions, learning disabilities, and it's becoming very difficult for them to manage their periods. And whether it's normal uterine bleeding or abnormal uterine bleeding, it can be distressing to patients who have learning disabilities. They may just get scared by the sight of blood. They may have premenstrual symptoms, which can make it very distressing to them and their carers. And it's important to assess what the patient's knowledge is about menstruation, whether they are able to consent or not. It's important to respect the patient and maximize their autonomy. The incidence and the problems associated with abnormal uterine bleeding are similar in these patients as they would be for anybody else without a learning disability. So the same principles apply to them. But there are some things to take into account. Lots of patients will desire amenorrhea because of the difficulty in managing their periods, but it's not always achievable, and it's important to explain that to the parents. A lot of parents are concerned about sexual abuse, and they will ask for permanent sterilization. But the risk of failure is high in these patients. It's not going to be effective in management of abnormal uterine bleeding. Patients will also ask for hysterectomy, okay, if none of the sort of first line medication, none of the other hormonal methods are effective, but there are a lot of ethical and legal considerations to take into account, because the parents may not always have their child's best interest in mind, and that raises a lot of concerns. Okay, we hardly ever do a hysterectomy for these girls. Depo-Provera or the Mirena coil, they are very, very effective in controlling. These girls may need a procedure and a general anesthetic, but very, very effective in managing these patients. And of course, you may have a scenario where there is abnormal uterine bleeding in adolescents with cancer. And there could be lots of reasons why they could have abnormal uterine bleeding. It's very rare to have genitourinary cancer, especially, I mean, it was more reported in the era of diethylstilbestrol, but now it's very, very rare to find girls with cancer. But they may have other cancers, and that can induce thrombocytopenia, or it can be chemotherapy-related thrombocytopenia. And it's important that you take advice from other experts that are involved in her management. And again, the Depo-Provera and GnRH analogs form the mainstay of management of bleeding in these patients. So I'm not going to go into a lot of details about the infrequent periods, but as we've already discussed PCOS, how difficult it is to diagnose in this age group. And infrequent periods could also be related to eating disorders or related to heavy exercise. And girls are getting a lot more conscious now about their body weight and how they look. And they need educating as to how that's going to affect their long-term gynecological health and their bone health. And again, you need input from a multidisciplinary team when you're managing these girls. You may need to involve the mental health team. You may need a dietitian. For them, it's important to take regular calcium, vitamin D, because of the risk of osteoporosis. And it's important to monitor their bone mineral density regularly every 2 to 3 years. The combined pill can be used for induction of the periods, or it can be used to regulate periods if they have infrequent periods. The only disadvantage of using the combined hormonal pill is that it does go through first pass metabolism and therefore reduces the bioavailability of estradiol, and therefore the patch, the 17-beta estradiol patch, is more recommended for girls in this group. And it can be combined with either the Mirena coil that provides the progesterogenic arm, or a cyclical progesterone. Okay, so just to highlight a few key points, I think I'm conscious that I've overrun my time. So just a few key points that these disorders, the abnormal menstrual bleeding is very common in the adolescent age group, but a lot of these patients can be managed in the primary sector or by the general gynecologist with reassurance, simple analgesia, and hormonal methods. And a careful history taking and investigations form are very, very important in managing these patients and making sure that you're not missing out on important medical conditions, like especially coagulation problems, because it's the first time that this may come to the surface. We discussed about some challenging scenarios, and it's important to take an input from a multidisciplinary team in the management of these patients. So we talked about coagulopathy being the second leading cause of menstrual dysfunction. STI is very important to take a sexual history from adolescent girls. And it's, as I explained, it's a difficult topic, but try and find a way to speak to the patient alone and reassure them that the information is confidential. And the combined oral pill is very safe and effective. There's a lot of hesitancy from the parents to use it, but it's very, very effective. And a lot of patients are concerned that it may cause weight gain and concerned about growth spurt, but there's no evidence to prove that. Okay, so I would like you to read this chapter that I have co-authored with Dr. Meenakshi Chaudhary. It's still in the press, but we are hoping it will be out. It's a good book for gynecologists who are interested in pediatric adolescent gynae, and covers lots of different topics. So I'll be really pleased if you can read this book and hope you like the chapter that we've written there. It provides an overview of abnormal uterine bleeding. I've just sort of listed some learning resources. So BRITSPAG, which is the British Society for Pediatric Adolescent Gynecology, is a good learning resource. There are lots of sort of guidelines there for professionals, lots of patient information leaflets, so that you can direct your patients to. The FSRH talks about all the hormonal methods and the UKMEC criteria. So when you're sort of deciding which is the safest medication for your patients, you can always refer to this website, the NICE guidance. And there's a paper that I would like you to read. This paper gives a nice overview of all the different kinds of medication and their role in menstrual disorders in this age group. Right, so I think that's it from me. Thank you. I hope you found it useful.
Thank you, Mukdha. That was very nice, exhaustive, and of course, a very, very detailed information, but very clear and transparent. From almost everything you have covered regarding the AUB, not only in the adolescent, but also embarking on the children and a little bit into the adults. I do understand that IV estrogens is not available. You said not available in NHS, but in India also we don't have it. So I don't think we can give it, as you said. And of course, pills do have their own reservations, but slowly India is also becoming very broad-minded, and the adolescent cultures are changing. And perhaps what you see in UK for the sexual activity here, maybe it is not coming into open, but people do go through lots of those episodes. And it's very, very important to take the history and not always think that maybe adolescents are not into this. So I think it's you have completely stressed on that, and that's the right way to go. That's what I feel. And of course, the IUCDs, as far as I feel, unless it is really, really required in India, we don't have a little favor towards IUCD for the very fact that it's hard to convince them to go through those kinds of vaginal manipulations. And that apart, of course, you covered everything, all the definitions, all the factors of the palm coin and coin in specific. Thank you very much for the detail, and also for guiding many lots of people what all to consider and read to get a little more clarity on the topic. Thank you, Mukdha. Thank you for your time, and thank you for logging in from UK. Thank you.
Yeah, it's been a pleasure. Thank you.
And I also take this opportunity to thank our local coordinators, and especially Lakshmi and Jyoti and all the people who have supported this program. Thank you very much from me for the opportunity as well. Thank you.
Thank you, Lakshmi ma'am, and Dr. Jyoti from my side also. And well done, Dr. Mukdha. Very well explained.
Thank you.
Thank you very much, ma'am.
Yes,
Now proceeding into the next lecture. It's a great pleasure and privilege to introduce our esteemed chairperson for the next session. I would like to introduce Dr. Mala Srivastav ma'am. She is the senior consultant and professor of gynec endoscopic surgeon and robotic surgeon, Sir Gangaram Hospital, New Delhi. She is the zonal chairperson of ISOPROB and secretary ISOPROB, New Delhi. She is the past joint secretary of IMS 2016-2019, and she is decorated with various awards. Her special area of interest are in gynec oncology and robotic surgery. Welcome, ma'am. Then I would like to introduce our next chairperson, Dr. Ajay Mane sir. He is the medical legal consultant since last 18 years. And he is the chairperson of Sexual Medicine Committee 2014-16 and past president of Aurangabad Obs and Gynae Society. At present, he is chairperson of official AMOGS website, and he had many international and national publications. Welcome, sir. Then I would like to introduce, I would ask Dr. Mahalashri Orsa ma'am to introduce our next speaker, Dr. Archana Hattin ma'am.
Good evening, everyone. It's my pleasure and privilege to introduce the esteemed speaker of the evening, Dr. Archana Hattin. She is the consultant obstetrician and gynecologist, University Hospitals of Derby and Burton. She has been RCOG Medical Training Initiative Regional Lead, Clinical Tutor, University of Birmingham. We are waiting to hear from you, Dr. Archana, your scientific deliberation. Over to you, Dr. Archana.
Thank you. I'll start with my presentation, and let me just get my.
In the meantime, I would like to thank the organizers to having me here. And it's always a pleasure. Whenever Dr. Lakshmi invites us, we are always ready to join her program.
Okay, I'm going to start my presentation on abnormal uterine bleeding. So I'm a consultant gynecologist and an obstetrician at University Hospital of Burton and Derby. My special interests are colposcopy, outpatient hysteroscopy, and I've also done a one-stop menstrual clinic, which is a new concept in the UK. And so I'll just kind of go through my experience here. And I can see, abnormal uterine bleeding is bread and butter for everybody. So it's something we all do. It's just how we manage differently here and there. So I'm just going to go through common things. So I'll start with how common it is. Basically, worldwide, it has a significant impact in women's health, especially in the reproductive age group. Prevalence, they say, is around 3 to 30%. Again, it's very widely reported, ranging from 3 to 30%, depends on which country and how the reporting is as well. It's definitely higher in the adolescent age group, as we've heard from Dr. Kulkarni just now about why it's higher. That's the hypothalamo-pituitary ovarian axis not being mature enough and how it takes time to mature. So that's why it's quite high in the adolescent age group. Again, coming to the other side, the 4th and the 5th decade of life as well, it's higher. Approximately 1/3 of the women are affected at some point in their life. So it's quite a significant complaint from women and definitely needs a lot of attention. So like Dr. Kulkarni has already covered, I'm not going to go into the details of this. So there was the classification system by the figo, which came in to make it clear, the terminology is more clear, and the nomenclature could be similar globally, so that we could all talk in the same language and we could understand each other better, again, for publications and books as well. Using this system of classification makes things a lot easier, so that we're talking in the same terms. As already discussed, the FIGO system 1 is standardizing the definitions and using it in non-pregnant women, and the FIGO system 2 is the etiology. So we've got 2 parts to it. One is the structural part, which is the palm part of it, and the non-structural part, which is coin. And that's what's used at present. I will elaborate a bit more as we move on. It's very important to know what is normal menstrual parameters, because without knowing what is normal, we're a bit lost. So I would, I want to emphasize on that. So frequency of the menses is important. So there is variation between patients, as all of us know. So it's important to identify what is normal and then take it from there. So the frequency of the menses is between 24 to 38 days. Regularity, again, is important. So it's less than 7 to 9 days. Duration, it should be less than 8 days. Volume is quite difficult to define. However, it's a subjective assessment of the amount of blood loss and how it interferes with the woman's physical, social, emotional, and quality of life. So moving on to what is abnormal, I think we've described this already, so I'm not going to waste too much time on this. But again, important is the frequency, the regularity, the duration, and the volume. So coming to definition of abnormal uterine bleeding itself, it's any bleeding from the uterus that is either excessive, more than 7 days, or scanty, less than 2 days, or delayed for more than 35 days or unexpectedly early, that's less than 21 days. Or this is also important, non-menstrual like intermenstrual bleeding. A lot of patients come with intermenstrual bleeding, post-coital bleeding, and again, post-menopausal bleeding, which is very important. So I'll just cover a bit of that as well. So terminologies what are commonly used now is, the main thing is abnormal uterine bleeding. It's acute and chronic. So we define it as chronic when it's more than 6 months, and intermenstrual bleeding, post-coital bleeding, and the other one is heavy menstrual bleeding. So going to the system 2 for the FIGO classification, that is based on the etiology. So we've got the structural and the non-structural. So predominantly the non-structural is been covered by Dr. Mukdha. So I'm going to try not to overlap things so that we can cover the rest. And so in the palm, it's polyp, adenomyosis, leiomyoma, malignancies, which also include endometrial hyperplasia. Again, in leiomyoma, there's a subclassification of different types of fibroids. In the non-structural, it's coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not otherwise classified. So there is a subclassification in leiomyoma. I think leiomyoma's fibroids itself is a big topic, which can, all of us can spend days together discussing. So I'm not going to go into the details of management of fibroids here. But as you're all aware, we tend to use the FIGO classification now so that, it's easier when communication between ourselves and writing up things, and even for publications and things. So there is the submucosal type and the others. So this is what we should be using when we're, seeing patients in a day-to-day management. Again, very important, multiple causes can exist for abnormal uterine bleeding, and the FIGO classification, so you have to identify and see if there's different causes. There can be causes from the structural part and the non-structural part. So I think sometimes we've got to keep our eyes open and not try to think it's only one thing, because there could be causes which can coexist. So it's really important. And again, causes vary depending on the age group of your patients. Of adolescents, clearly it's different causes, and women in the perimenopausal age group, again, it's quite different. So it's important to consider that. So just kind of quickly gone through a list where I've tried to show you what are the age-related ones. I have put in neonatal because sometimes mothers do come with some spotting in babies, which is again mainly due to estrogen withdrawal, which just needs reassurance. Pre-pubertal as well, they can come in with foreign bodies, traumas. Sometimes, you have to keep your eyes and ears open and consider sexual abuse as well. Infections like vulvovaginitis, urethral prolapse, precocious puberty, ovarian and vaginal tumors. Coming to post-menarche, mainly anovulatory and bleeding disorders, which we've discussed already in a previous talk. Infections, especially pelvic inflammatory diseases, and also to consider polycystic ovarian syndrome. Pregnancy, yes, as we've just had a discussion, times are changing. Younger women, girls are also being sexually active. So always to consider pregnancy. Moving on to the reproductive age group, again, anovulatory cycles is quite common. Pregnancy itself, always to be ruled out. Polyps, adenomyosis, fibroids, cancers, infections, endocrine causes like polycystic ovarian syndrome, thyroid problems can exist, and pituitary adenomas. Bleeding disorders, I think it's more towards, immediately post-menarchal than in the reproductive age group. But again, that could have been missed because people just put up with a lot of things, and heavy bleeding is something which they could have just been put up with, and then they present to us later on. Again, important to bear in mind iatrogenic causes, especially with a lot of hormones being given as contraceptives, and it could be one of the causes as well. Yeah, moving on. So very important, how you assess patients who come with abnormal uterine bleeding. I've just put down the principles of it so that we can just get a quick idea. So it's very important to establish whether it's been on time or is it been on for a long time, so acute or chronic, and always very important to exclude pregnancy. Take relevant gynecological history, because associated symptoms can actually point you towards the direction as to what the cause could be, like associated dyspareunia, dysmenorrhea, and relevant gynecological history, abnormal vaginal discharge, sexual history. All of this is important, and even smear history, which is very important, and taking obstetric history. All of these are really important. Examination definitely should be done. Again, in the UK, we have primary sector and secondary sector. So the NICE guidelines, that is what we tend to follow here, does actually say that examination is not always necessary. I will discuss that with you in my next few slides, and how during COVID times, examination has been fairly difficult, and how we've had to change things here. So I'll kind of get to that in the next few slides. Red flag symptoms are very important. I'll get to those as well, because these are symptoms which can be flagging up cancer. And so it's very important that we look for the red flag symptoms. A full blood count to make sure the patient's not anemic, history of cervical smears, taking swabs to rule out infection, and again, coagulation screen as relevant only. Imaging is, as we all know, transvaginal. Again, if that can't be done or patient refuses, then transabdominal scan, hysteroscopy, and hysteroscopic guided biopsies, depending on the need for an MRI scan. Sorry. So yeah, I'm going to cover abnormal uterine bleeding in different ways. So I'm going to start off with heavy menstrual bleeding. So I think we all know the definitions. It's excessive bleeding, which is affecting physical, social, emotional, and quality of life. It does have a significant impact on the quality of life. Over the years, the management of heavy menstrual bleeding has definitely changed. Hysterectomy was done quite often, but now I think it's quite rare, especially in the UK, where we try a lot of things before, and even the funding is based as such that we should have tried the medical line of management, tried the coil, or at least offered the coil, then the endometrial ablation, and then last resort is a hysterectomy. So that's how it works for us. So it has changed in the last few years. So I think we've covered this. Yeah, so one thing I wanted to emphasize here is the NICE guidelines that came out in 2018 actually recommend medical treatment.
Button down. Let's do this. Ready? Come on. All right, let's find a nice 75 to 90 on your cadence on that speed. Resistance, build it to a 25.
Okay, so sorry, I'll get back. NICE guidelines in 2018 actually recommends medical treatment can be started without examination if no associated symptoms or risk factors are present. So based on this, we do have a lot of patients being managed in the primary care where they can be started on the first line medical line of management. So that's equally important. I'm sure in India as well with COVID, we've had a lot of Zoom consultation, WhatsApp consultations. So, we would be fairly justified in starting medical treatment without actually seeing the patient and examining the patient, as long as a good history has been taken. So that's that. Based on history, the first on history and examination, first line of investigation, is outpatient hysteroscopy or transvaginal scan. Outpatient hysteroscopy can identify submucosal fibroids, polyps, persistent intermenstrual bleeding, and also identify risk factors. Main thing is if there are risk factors for endometrial hyperplasia, then outpatient hysteroscopy is what we offer here first line. And previous failed medical line of management, age more than 45, all these patients definitely we offer outpatient hysteroscopy. Transvaginal scan can be offered after hysteroscopy, especially if you haven't found anything and the cause, you're thinking more, or if you're thinking more in terms of fibroids, then transvaginal ultrasound scan would be the first line. So I wanted to just mention about the one-stop menstrual clinics which we run here. So basically these are clinics where we include the consultation, either do a transvaginal scan or an outpatient hysteroscopy, get bloods at the same time and offer treatment at the same time. So it's see and treat clinics where, if you do find a polyp, we remove them at the same time, insert a coil, or even offer the ablation as well. Again, before ablation, we do always want to take a sample, make sure that there's hyperplasia or any endometrial cancer is ruled out. So if you've done a hysteroscopy, cavity looks okay, you've taken a sample, we do tend to offer ablation at the same time as well. So outpatient hysteroscopy, I wanted to just cover that, what we tend to do here is a vaginoscopic approach without cervical dilatation. With the latest scopes, they are very small scopes where we tend to use really thin 3 millimeter scopes. We don't tend to do any blind biopsies. Sometimes we do, but it's not what is recommended. They are very well tolerated by patients and they are cost effective. Like I mentioned, see and treat approach is what we tend to do. So endometrial ablation, again, it's a minimally invasive procedure. The main thing it does is destroy the endometrium, and this is mainly used for benign causes. Very important that the patient doesn't desire any further fertility. Now we tend to use the second generation techniques, which are non-resectoscopics, and there is a good reduction, about 90% reduction in heavy menstrual bleeding. So it's one of the useful tools presently used. So there are different techniques, as we're all well aware: thermal balloon, endometrial ablation, impedance bipolar radiofrequency ablators, the Nova Show, which is commonly used here. There's also the hydrothermal ablation technique and the endometrial cryotherapy as well. So Nova Show is what we tend to use commonly here. Okay, I'd like to cover about LNG-IUS as well. So this is again one of the first line treatments which we offer. This is actually the first line, then the ablation. How it works is it releases progesterone and inhibits the endometrial proliferation, thickens the cervical mucus and suppresses ovulation. There's about 70 to 95% reduction in the bleeding, and about 50% actually have amenorrhea in the first year. It's very cost effective. Main side effect we're all aware about is irregular spotting in 3 to 6 months. However, it does tend to settle. So we always advise patients that it's the first 3 to 6 months which can be quite difficult, but once you've gone through that, it really works well. So this is what we presently practice in our trust. I've just got my trust guideline here. So heavy menstrual bleeding without any symptoms, like I said, can start pharmacological treatment. And I'm not going to go into that. I think we've already covered that previously. So I'm just going to move on. So with additional symptoms, especially if you're thinking of submucosal fibroids or a polyp, or it is persistent instrumental bleeding, or risk factors for obesity, polycystic ovarian syndrome, or if patients on tamoxifen, or if previously unsuccessful medical treatment, like I said, we'd offer outpatient hysteroscopy and endometrial biopsy. And like I've already discussed, the approach is a see and treat. So at the same appointment, we've tried to find out what's happening, and then we do offer treatment. Not all patients would want at the same time, but it is something we offer so that the number of visits are minimized and it would help. If we're thinking of fibroids, definitely an examination is required. An ultrasound is what we do next, depending on the size of fibroids or if there's suspected adenomyosis. If the fibroids are small, less than 3 centimeters, and then the first line would be a Mirena coil. Again, if patient declines, other pharmacological treatment, and then subsequently surgical treatment, which would be ablation or moving on, then hysterectomy. Again, if fibroids are quite big, we just have to manage fibroids, and ablation may not be suitable. Again, one of the criteria for endometrial ablation is uterocervical length being less than 12 centimeters. So that's something we have to bear in mind. Again, last resort is a hysterectomy. So again, this is another, flow chart to show how we would manage, but I think we've kind of covered this. I'm probably not going to elaborate. I'm just conscious of time as well. So next thing I want to cover is intermenstrual bleeding. So any bleeding which occurs spontaneously or predictable between the periods, it can occur randomly. It can be cyclical or it can be non-cyclical. Sometimes it can be early part of the cycle, mid-cycle, or sometimes late cycle. It is troublesome symptom. Incidence is about 24% in perimenopausal women. Common causes are polyps, infections, ovarian causes, iatrogenic causes, and malignancies. So persistent intermenstrual bleeding is a red flag symptom in the UK. So patients get referred to as a 2-week wait referral, where they tend to be seen in the secondary care within 2 weeks. The main reason is to rule out any cancer. So that's something which needs to be considered. Again, postcoital bleeding is bleeding after intercourse, as it's very self-explanatory. Prevalence is about 0.7 to 9%. Common causes are polyps, cervical erosion, cervicitis, that's infections, PID, endometritis, and we have to bear in mind it could be CIN as well, cervical intraepithelial neoplasia, and cervical cancers as well. Again, in the UK, it is a red flag sign. All patients do tend to get referred to colposcopy clinics, and it is referred as 2-week wait referral pathway, because the main worry is cervical cancer, especially if there's no good smear history. They need to be seen fairly quickly. To touch a tiny bit about postmenopausal bleeding, bleeding occurring after 1 year of amenorrhea is defined as postmenopausal bleeding. Incidence is about 10%. Very important to remember that 10 to 15% of patients who present with postmenopausal bleeding can have endometrial cancer. So a prompt and effective evaluation to exclude cancers is what we need to do. It is a red flag symptom again, so they need to be seen within 2 weeks of them presenting to the primary care. Common causes, as we know, is atrophic vaginitis, sometimes polyps and fibroids, but again, 10% chance of endometrial cancer, and hence the importance of being referred to secondary care. So patients are offered a transvaginal scan. Most patients are seen in clinics called as PMB clinics. They are fast track clinics, so postmenopausal bleeding clinics, where there is facility to scan at the same time and also do a hysteroscopy, so they can be managed at the same time. It's a see and treat approach again. So scans to look for the endometrial thickness. So if the endometrial thickness is less than 3 millimeters, there's no need for any further sampling of the endometrium. The reason being 99% negative predictive value for endometrial cancer. However, if it's anything 4 millimeters or more, hysteroscopic guided sampling is what we do here. The reason being, if we do take any other kind of sampling, a lot of endometrial tissue gets missed, and cancers can get missed. So it's important we make sure we've taken a guided biopsy. Sometimes these samples come back as inadequate. I'm sure you guys have similar experience. However, as long as we've had a good look inside the cavity and the cavity is atrophic, and there's nothing to worry, patients can be safely discharged with reassurance. I'd just like to mention, if sometimes patients come back with recurrent postmenopausal bleeding, in them the approach can be slightly different. The 3 millimeter endometrium is not really taken into account, and we do offer a hysteroscopy just to ensure that there's nothing else happening. A tiny bit about polyps, because it's quite a common cause of abnormal uterine bleeding as well. 67% of premenopausal women present with either intermenstrual bleeding or abnormal bleeding. We all know the just localized overgrowths of the endometrial glands and stroma. Incidence is quoted quite variably as about 8 to about 35%. Most often they are benign, but can be malignant as well, especially in the postmenopausal women, where about 5% of them can be malignant. So offer them transvaginal scan, and again, offering hysteroscopies and to have a look. Treatment is excision. Again, if they're asymptomatic and they're more than 1.5 centimeters, we tend to excise them. However, smaller ones could be left behind, but I think most often all of them are excised, and it's a fairly easy procedure to do. So most polyps are removed and they're sent for histopathology. Tiny bit on adenomyosis. We all know adenomyosis is basically endometrial stroma and glands present focally or globally throughout the uterine musculature, causing hypertrophy of the surrounding myometrium. More in the 4th decade, multiparous women, 4th and 5th decade, and they present with 1/3 are asymptomatic. Otherwise, they present with heavy menstrual bleeding, irregular bleeding, dysmenorrhea, and dyspareunia. So transvaginal scan is what what is done to ensure, to confirm the diagnosis after examination. So echogenic striations, myometrial cysts, globular uterine enlargement, asymmetrical thickening of the myometrium, and poor definition of the endomyometrial interface is how we identify. MRI scan if in doubt, and treatment again is hormonal. We could start off with non-hormonal, doesn't really work very well, but otherwise hormonal. And again, the Mirena coil has been very effective, and it's offered. Endometrial ablation is not very preferred because it doesn't help with the dysmenorrhea, but we do tend to offer it. And again, uterine artery embolization. There is a bit on removing the adenoma, but it's not commonly practiced. And again, last resort is a hysterectomy. So So these are my references, and the NICE guidelines does have a detailed, it's more based on this present system here for the management of heavy menstrual bleeding, how it can be managed in the primary care and the secondary care. And so this is essentially the heavy abnormal uterine bleeding in a gist. Thank you.
Thank you, Archana Hattin, ma'am, for those all detail. You have explained very well about every detail of the classification and AUB new definitions, old definition. Because previously we were using that dysmenorrhea, hypermenorrhea, menorrhagia, and all the terms. Now it has become very easy, AUB and HMB. And subclassification, you told that it can be IMB, PCB, HMB, and causes of everything. Then you have given every treatment in very short. In one slide, you have given a treatment of that HMB, IMB, PCB, PMB, polyps, adenomyosis, and everything. It was very short but sweet and covering all aspect presentation by you. In India, we consider the endometrial thickness 4 centimeter instead of 3 centimeter. What to be considered for the further evaluation. And one more cause for that PCB is atrophic vaginitis. It can be another cause which is to be mentioned particularly. So it was very nice lecture and presentation by you. Thank you, Hattin ma'am. And at the end, I must convey my gratitude to Lakshmi ma'am and Jyoti Malik ma'am and my friend Josna from UK and Sushma Verma ma'am and yourself. Thank you very much. Nice presentation.
Excellent scientific deliberation, Dr. Archana. It was a pleasure to listen to you. We have widely covered the entire aspect of abnormal uterine bleeding. And that was very comprehensive, very informative, and really exhaustive. Thanks for your nice scientific deliberation.
Yeah, her flow charts were very excellent.
Very excellent.
Yeah.
Very descriptive.
Yes.
Thank you very much.
So after those wonderful talks, I would like to thank all my chairpersons for the 2 talks and both the speakers, Dr. Mukdha ma'am and Dr. Archana. Wonderful deliberations, and really, I mean, it was very explicit. So coming on to the third part of our program today evening, it is a great panel discussion, and I think we all are looking forward to our to this wonderful discussion that we are going to have now with our moderators here as none other than Dr. Lakshmi Shrikhande ma'am. So she is, we all understand, she is the person, the lady behind the show, and the chairperson-elect ICOG, the National Corresponding Editor Journal Obs and Gynae, the National Corresponding Secretary Association of Sorry.
Bus.
I just lost my screen. I don't know.
No, it's all right. Move ahead, yeah.
Okay, so I know.
Can I read from my side, Jyoti ma'am?
Ajay, this is enough. I told her to introduce in 2 lines.
Okay.
Yes, so Dr. Lakshmi Shrikhande, naam hi kafi hai.
हाँ, बस इसीलिए, so that is why she said, no, don't waste time on me, and let's
introduce the panelists and we will move ahead. Yeah.
And the other international experts we have, Dr. Archana and Dr. Mukdha for the same. And our panelists are the star panelist that Dr. Lakshmi has chosen for today evening is Professor Maninder Ahuja ma'am, the President of Society of Meaningful Life Management. She is Director Ahuja Healthcare and 40 years of dedicated work for women from adolescence to menopause. Next is Professor Uma Pandey, a young professor that Dr. Lakshmi was mentioning. She is a professor in head department of Obs and Gynae, Banaras Hindu University, Varanasi, examiner for MRCOG and a fellow representative of AICC-RCOG, was in the champion trial as well. Now, the third panel is that we have Dr. Richa Sharma, who's also another young professor that we have today on board from GTB Hospital, University College of Medical Sciences, Delhi. And she is the FOGSI MTP committee chairperson. She has been holding a lot of MTPs webinars now under her chairmanship, and we can see so many awards here in her CVs displayed. Then we have Dr. Divya Agarwal, another gold medalist, a fellow in reproductive medicine, Germany, IVF specialist, director, Ayushman Multispecialty, and Morpheus Akriti International IVF Varanasi, president of Varanasi Obs and Gynae Society. So welcome, Dr. Divya. Then we have Dr. Shailaja from Andhra. She's associate professor, Andhra Medical College, Visakhapatnam, Andhra Pradesh. She is secretary Obs and Gynae Society, Visakhapatnam, and was organizing joint secretary of Yuva FOGSI of South Zone. Presented many papers, publications, and last but not the least, we have Dr. Supriya with us, a very a person who's very active, seen in these days in many webinars, who is a consultant Obs and Gynae practicing at Supreme Hospital, Bhiwandi, and the West Zone coordinator FOGSI Adolescent Health Committee, is chairperson AMOGS, Adolescent Health Committee of AMOGS. So I would now leave over to Dr. Lakshmi ma'am for the wonderful panel discussion that we are waiting for.
Yeah, thank you. Thank you so much, Jyoti, for introducing all the heavyweights, our experts for this panel discussion. And you know, all our professors, associate professors, they have made my job easy. And more so, my job has been made easy by Mukdha and Archana, because practically speaking, they have covered everything. If you all were attentive, so we are just discussing the theory part from the theory, how to convert the theory into practical part. And AUB, you all will agree, whether you are practicing in private setup or public setup, day in and day out, we do get cases of abnormal uterine bleeding from adolescent to menopause. So in this panel discussion, I have tried to cover all the aspects from adolescent to reproductive age group to perimenopause and menopause, because at every phase of woman's life, the cause and the management differs. So this is the first case for our professor, Dr. Uma Pandey. Dr. Uma, she is the 14-year-old and she has come to you with regular menses but heavy menstrual bleeding. And since this is the first case, so you have to tell the audience what are the relevant points you would ask in the history. She's just 14 years old.
Thank you very much, ma'am. I would like to say that the most important thing in this case is the history, actually, because majority of our girls, they may not get investigated, and your treatment may base on the history. So obviously you will ask her age, or it may be written in the requisition slip already. When did she achieve her menarche? That is important. And how long she bleeds, and what is the frequency, like she bleeds at 30 days interval and 5 days, 6 days. Are the cycles regular or are they irregular? Because irregularity will suggest many things. Already we have discussed, both Dr. Mukdha and Dr. Anita has discussed many points according to this. Then it is a good idea to ask was there a history of amenorrhea? Also in these days, in a person of 14 years of age, it is a good idea, and it must be done, to ask whether she has been sexually active, or is there any history of sexual assault. It is a good thing to do that. Then if you have to ask if she was having dysmenorrhea. That will perhaps in a way will tell you regarding prostaglandin and all that ovulatory cycles. Then now comes the other part. You have I will ask that young girl or her mother, does she bruise easily? Like suppose if she has hit the table suddenly and she has bruised. Has she had?
Just a minute. Yes, because apart from whatever points you have said, I would like to re-emphasize one point, that in India, we doctors shy away from asking about the sexual history. So please don't shy away. Don't ask in front of parents, but when you are there with the girl alone, do ask her, and you will be surprised to know that majority of our young adolescents, they are sexually active. So Uma, you have rightly covered all the points, and I know you are going towards the coagulation disorders, because in this young woman, young adolescents, coagulation disorder comes first and then is the ovulation. So yes, Dr. Uma is telling us whether we should screen for coagulation disorders. Answer is yes. And what are the criteria which will prompt you to go for evaluation of coagulation disorders is what Dr. Uma is now elaborating. Yes, Dr. Uma, what points our participants should ask which will prompt them to evaluate for coagulation disorders?
History of easy bruisability, I said. Many people like हमें घर में चलते चलते अचानक मुझे ठोकर लग जाती है, तो मुझे ठोकर लग जाती है मेरे ही टेबल से, but I don't bruise, I don't make a form of kind of a hematoma which is more than 2 centimeters in size. But if that woman is doing that, if she while brushing, if she's bleeding, and that it's even if there are 3 days, 3 mornings that she has had this bleeding when she was brushing her teeth, that would also suggest that she could have bleeding disorder. Some most important clue in this woman would be, in this girl would be, if she has been having heavy menstrual blood loss since she started menstruation, menarche. Usually 40% of the cases of anovulatory bleeding and heavy bleeding when at the time of menarche, they are due to coagulation disorders. And also many times if you sit down with the family members and ask regarding the family history, you will get the family history of von Willebrand's disease you might get. And so therefore the family history is also very important. Apart from that, we have to also inquire regarding, in general, we have to take the endocrinal problems into picture, like coagulation, thyroid disorders, PCOS, features of PCOS. That is just to take to cover a wider picture.
Yes, Uma, we know Dr. Mukdha has told us about the various tests for coagulation disorder, and I am sure you are not going to order all the tests. So what are the tests you will order, and what common bleeding disorders you will think of in this girl?
Usually, even if I order all the blood disorders, our patients, they're not rich enough and they don't get it done, to be honest with you, ma'am. So far in my life, I have only been able to get one von Willebrand's patient who was diagnosed by that, completely diagnosed, and she was pregnant. But otherwise, yes, definitely platelet I would go because of recent resurgence of dengue and all those things. Apart from that, I will go for APTT, PT, and also you have to find out if the liver function, if the kidney functions, they are doing fine, because they will also result in problems. These are the minimum tests if patient can afford, and pelvic ultrasound in that girl as well. If that patient can afford, yes, I would go ahead with von Willebrand's factor, and it is they report in proportion. It is 40% or 20% lesser than that. So then I will do that as well.
Yes, and now how he will manage, because she is towards coagulation disorder, because hormones we are discussing in subsequent cases. So how you will manage her and how you will do follow up for her, and then I will invite Mukdha for her comments on this case. Yes, Uma.
Yes. When the girl comes in my OPD, usually they are pale, there's hemoglobin of 6 or something, and they are bleeding. So obviously we have to control the blood loss. I start with, in my OPD, I would start with oral contraceptive pill in this girl, although she's 14, knowing that 3 times a day to start with, along with tranexamic acid. Most of them are cachectic. So I give half tablet tranexamic acid along with mephanamic acid to them. And I admit them because of their severe anemia, arrange for blood, and slowly the bleeding reduces. Then once they're fine, they go home after blood transfusion and reduction. And then I have to continue with the oral contraceptive. How? The oral contraceptive pill, which was started 3 times a day, will go to 2 times a day. And eventually I reduce it to 1 time, and then keep an eye on that girl to come with the other investigations which we have ordered, and then see that. if that has controlled the acute phase is sorted, hemoglobin is sorted, then yes, we can go ahead with progestogens in the form of 5 milligram. That's another option I have. Then yes, you have to give iron tablets to this lady so that she doesn't become anemic. You have to obviously give protein. You have to also add folic acid. And I would always refer this lady to our hematologist once, so that they give their opinion to us what else we should do.
And how frequently you will call her for follow-up?
When the first time I have sent her home, when the bleeding was secured, then once after 1 month, when she has completed her BD dosage of oral contraceptive pills. Once she has come and she is still doing fine, then I will make her oral contraceptive pill once in a day and again call her after 1 month. After that, either I have two options: either I start progestogen, or else if she's doing so well with the oral contraceptive pill, might as well continue oral contraceptive pill for another month so that she doesn't drop her hemoglobin like the way she was, and then see her and then take a decision from there.
Yes. Mukdha, now I invite you. Now you have seen how in India we manage such kind of cases. So what is your experience and what are your expert comments and inputs on this case? Mukdha?
Yeah, I agree. Very nicely described, Dr. Uma. My only comment is that it says that this is a stable patient. So I wouldn't admit a stable patient. I mean, you need to take a good history. You need to ascertain whether she's got anemia. And you don't need to wait for all the investigation results to come through to start their medical management. And it's important to know whether her cycles are regular with heavy menstrual bleeding, or they are, I mean, it says they're regular.
This is
so
regular, heavy, and stable.
Yeah. So you can start with tranexamic acid as first line, and you can start with mephanamic acid while she's being investigated. And I agree with what investigations have been requested. I don't know whether she mentioned thyroid function.
Yeah, she mentioned. We do routinely thyroid, yeah.
Yeah, it depends on the history again, if she's got any symptoms of hypothyroidism. So my first line will be tranexamic acid and mephanamic acid if it's regular periods with a stable patient. And then I usually see them back in clinic in 3 months' time. It's important to explain to the patient that with any management for abnormal uterine bleeding, it's not one size fits all. So we often have to trial different medication and work out which is best for this patient. Also with hormonal medication, if you start them on the pill, it's important to tell them that this pill may work for you, it may not work for you, but it's important to persevere on this pill for at least 3 to 4 months, because your body is going to get time to adapt to any medication that you give. So that is my first line. That is what I would say. And then,
but in India, if any girl or woman comes with abnormal uterine bleeding, we do screen for thyroid. I mean, we don't wait for the symptoms or signs of hypothyroidism.
Okay.
I mean, this is our practice. At least if not affording, we do order TSH.
Can I also just add one line, just last line?
Yeah.
In our setup, it is so difficult for this woman to send this girl to send her home and let her come back after 3 months. They will never come to you. It's very difficult. Trust me, it's very difficult.
Yeah, in rural settings and all, it's really difficult because parents are working, so they are not able to bring the girl very frequently to the hospital.
Yes, ma'am.
Do patients have phones, telephones? Can you ring them? Can you arrange telephone appointments?
Everyone has got telephone now, all 14-year-old girls.
One has telephones, but they don't use it for this purpose.
Yeah, they don't use it. That is what I tell in my OPD, Baba. Telephone ka upyog uske liye bhi karo. There are so many apps related to health. Yeah, you are right, Shailaja.
No, what I'm saying is that for follow-up, patients will not come to you because they are busy, parents are busy. But, a telephone is a good way of following up as well, that, you can arrange appointments in a few months' time and you can ring them up and I mean, that may help to avoid unnecessary admissions of patients.
In my practice, only 15% patients will talk to you on telephone and tell about their health, not others. 15%.
Yeah, Mukdha, because Dr. Uma is professor in Varanasi. So, I mean, everywhere the geological differences are there. Yeah.
Sure.
So this was the first case where I wanted to highlight the coagulation disorders, because most of the times our treating clinicians, they just think of anovulation and they just start OC pills without even asking about the coagulation disorders, especially in the young adolescents. So this was the case to highlight coagulation disorders. Now this is the second case, Dr. Richa. She is again a young adolescent, 15-year-old only, but she is having irregular menses and she has come to you with heavy menstrual bleeding. She is a stable patient. So I want how you will confirm that this is really heavy bleeding or it is just a subjective perception of that girl. Can you make out objectively that this is really HMB? Richa?
Yes, ma'am. First of all, I thank you for inviting me. Now, the diagnosis of heavy menstrual bleeding is always in the relation to our previous cycles. So we have to consider, we have to ask whether the bleeding is interfering her physical, social, or emotional quality. So to be more precise, whether it impacts her daily life, like missing the schools or missing the sports or any other social activity. Now, considering the normal cycle is between 7 to 21 days to 45 days, so we can ask how many pads that she was changing previously and now, whether she's changing more frequently, or if she is changing the pad more than within 2 hours, if she is changing, completely soaking the pad, or if there is a flooding, or if she is staining her clothes despite she is wearing the pad, if she is staining her clothes, staining her bed, then also we can think that she is having a heavy menstrual bleeding compared to the other side, or she is bleeding for more than 7 days, then we can think that she's bleeding more than the previous cycle. Then
Richa, there are Richa, there are certain charts which are available.
I'm coming to that.
Yeah.
So the children, they are very clever and very smart. They usually tell about it in terms of pad use and things like that. But the charts usually we don't use in our OPD. But at times, like if they are not able to tell the pads, then we draw the chart and they say we ask them whether it was a partially soaked or superficially or completely soaked, and then whether the clot was present or not, a small clot and then big clot. And then in terms of flooding, so that that is this thing pictorial blood loss chart.
Yes.
Then we multiply how many charts they have, how many pads they have used, and then we multiply. If it is a superficial, we multiply by 5 or 1, 5, and 20, and so on. And then the cutoff usually it is 100. And if it goes more than 150, it is said it is a heavy menstrual bleeding. But we don't usually actually use it. It is more of a theoretical.
No,
and
but
more of comparing the when we do any treatment.
Yeah, Richa, you have rightly pointed out, because in every case you don't have to use those charts, but somewhere as a treating clinician you do feel that this is not really heavy menstrual bleeding what your patient is talking, and in that cases it is beneficial to have an objective assessment, because as a clinician we should not miss out anything. So to all the participants, those charts are available on Google. You can download it and you can use it. Now you have confirmed, Richa, that she is really having a heavy menstrual bleeding. Apart from coagulation disorders, I think Uma has covered all the points. Would you like to add something more in the history and the lab testing in this girl?
So apart from already covered, I would like to ask her about the sexual history also. I have to rule out the pregnancy. I have to rule out. And then if she is on already on any drugs, what if she is already on a hormonal contraception, or she is on any anticoagulants also? So we have to rule out that.
Yes.
And then coming to the investigation has already been pointed, but I also do in my patient, apart from doing the hemogram. Hemogram tells us a lot of things. Apart from the HP value, it tells us about if the platelet is low. What if she's having a ITP also, idiopathic thrombocytopenic purpura? Then leukocytosis, excessive leukocytosis. We also got few patients who had the leukemia. Then peripheral smear for type of anemia, and also the abnormal cells also we do to pick up the other patients. Then once we put them on the treatment, if they are not resolving, then we do the menstrual blood. We send the menstrual blood for TB PCR, and we do for AFB smear and culture also. So quite a lot patient we got as a genital tuberculosis, we kept them on ADT and their problem got resolved. Then apart from that, if we do the history screening that Dr. has already pointed out, all the small trauma leading to bruises, ecchymosis and epistaxis and things like that. So usually I also do PT, APTT and this thing fibrinogen level. These things, because they give a lot of information whether their common pathway is working fine, their intrinsic extrinsic pathway is fine. Then apart from that, it also gives the information about the liver disorders also. If these things are elevated, PT, APTT. Then vitamin K deficiency also. So we give usually we give the 3 injections of vitamin K also to these girls. Then apart from that, coming to the ultrasound, yes, I do the ultrasound because ultrasound also gives an important indication. It's not that all the adolescents will have the anovulatory cycle and they have the excess immaturity and the coagulation disorders. Although the polyps and the fibroids, the frequency is very less than 1%, but still I would like to put a probe on the abdomen and rule out polyps or any fibroids in these patients. And apart from that, liver and spleen also, hepatosplenomegaly also, which can be missed in the examination, can also be picked up. What if she is having a leukemia again or ITP? It can indicate that. And then ovaries also, it can be indicative of PCOS also, and then endometrial thickness also we have to see. Then coming to differential diagnosis, we have already covered. I think it is anovulatory and then hormonal and hematological. And then most important thing is that the foreign body history also we should take, adolescent girls, and any history of assault also we should take. So that is important. And coming to the treatment part now, since she has a irregular menses and heavy, so I will put her on the hormones. So usually what we do is a progestin, we give norethistron, usually we give 5 to 10 milligrams 3 times a day, and then we taper once the bleeding settles. For this, I make it a cycle of about 28 days, and from then next cycle onwards, we switch over to OC pills. But some patients, they have the inhibition of taking the OC pills. They say, oh, this is a family planning tablet, why we should take? So then those patients, we continue them taking the norethistron. Then few patients, we have given the DIMPA also, 3 monthly injections they had opted. Then intrauterine, this thing, Mirena also it works, but I have never used for the adolescent patient. Maybe we can use if they are sexually active and they have a heavy bleeding and all, maybe we can use, but I have not used.
But
for,
is really very difficult in any scenario using LNG for a 15-year-old. Even if she is sexually active, she will not accept in front of parents, and you can't convince the parents that you are going to insert the LNG. She might confide in your ears that she is active, but you can't write it on file. So this is a tricky situation for us. Yeah, I know.
So I have never used that.
Yeah.
So, and then regarding follow-up, yes, once her bleeding is controlled, and yes, I will also give hematinics also, and folic acid and vitamin C we will give her. And then I usually follow up in the next cycle after the next menses. And if she is working fine, then usually 3 monthly and so on. They will come.
Yeah, Mukdha, now I invite you. We have heard the Indian side, how we will manage a case of anovulatory AUB at such a young age. Your inputs, Mukdha.
Thank you, Dr. Richa. Really well explained. I just wanted to make a few comments. In the history, I don't know whether she mentioned about any symptoms or looking for signs of hyperandrogenism. Because, you know, if you're suspecting anovulatory PCOS, then often in these girls, that could be one of the important signs to look for. Because as I explained, it takes time for the HPO axis to settle down. The ovaries look multifollicular at this age, so it's difficult to diagnose PCOS. But if her menarche was 3 years or more, or three or more years ago, then you could say that this is one of the clinical signs. The irregular periods is one of the clinical sort of symptoms of polycystic ovary syndrome. And also when you do an ultrasound scan, even if they have a thickened endometrium, the only difference in management is in adult women, you would think of sampling the endometrium, but that's not indicated for adolescent patients. It should be purely managed with hormonal manipulation. So I think that's it. And for my first line for her would be combined oral contraceptive pill to regulate periods as well as to improve the heavy menstrual bleeding.
Any specific combination when you are talking of combined oral contraceptive pills, which estrogen, which progesterone, and what dose?
No, I would start them on the commonest that we use here is microgynon and Rigberion, which is the standard pill. I know with the third or the fourth generation, the progesterones, they are better for the hyperandrogenism symptoms, like drospirenone, but you know that I wouldn't normally recommend that as first line. A standard pill should be equally effective in these patients because it will over a period of time improve the serum concentrations of sex hormone binding globulin and would reduce the free available testosterone and therefore help with the symptoms.
Yes, Mukdha, you have very well pointed out that to look for the signs of hyperandrogenemia, and within 8 years of menarche, we can't label her as a case of PCOS, even if we are seeing the multifollicular appearance on the ultrasound. So yeah, now let us go to the third case. Supriya, this is your case. She is 19-year-old. She has come to you with an acute heavy menstrual bleeding. She is feeling dizzy also. So what will be your immediate action?
Yes, ma'am. At the outset, let me thank you, Lakshmi ma'am, and the organizers for allowing me to be a part of such an august gathering here. And now this patient clearly you have mentioned that she has dizziness. So I'm expecting that she has some amount of, clinically unstable patient. She must have bled a lot, probably neglected over time. And therefore she's probably hemodynamically unstable. So first and foremost, in such case, definitely I will admit her, have a quick history and examination, and I will first and foremost try to stabilize her clinically. She may be in hypotension, hypoxic, she may have tachycardia, sweating and dizziness. So the first and foremost, we'll secure an IV line for her, give her fluid resuscitation, nasal oxygen if required. I would definitely quickly send some investigations, especially a hemoglobin, a blood and a cross match, apart from everything else that I will come to later, but this will be my primary, line of action. And once I get a hemoglobin estimation, if she requires maybe a blood transfusion, that will be my first concern. As soon as I can stabilize her fairly, I would next concentrate on what is the reason why she's bleeding such a lot, and then come to managing her menstrual problem. So maybe side by side, I would definitely like to add some injectable drugs, which will, like fibrinolytics, which will help reduce the blood loss. But first concentration will be on trying to stabilize her clinically.
You have stabilized. Now, what is your differential diagnosis in your mind? She is 19-year-old and coming to you for the first episode of acute bleeding.
Yeah, since she is 19-year-old, since in the adolescent group, apart from the PALM and the Cohen, we would, usually be concentrating on the Cohen diagnosis, that is coagulation disorders. Already they have been discussed. Ovulation dysfunction, that is maybe PCOD or some other, some associated endocrinopathy, some type of drugs that she's on, maybe some anticoagulants or antidepressants. However, I would definitely be concerned about she being pregnant and this being, something concerning pregnancy. For example, she may have had taken some MTP pills and she's bleeding a lot, or it's just a spontaneous abortion and she's bleeding a lot. So definitely I would make sure that I'm not missing out. And if she's having dizziness and maybe bleeding may not be too much in amount, but I would definitely also like to rule out an ectopic pregnancy. Because we have had unmarried girls come for the first time with ectopics, unfortunately for them.
I mean, I have personally encountered, I was too shy to ask a history of sexual history, and she turned out to be ectopic on ultrasound. And of course, here the sexual assault history makes a lot of sense.
Yes, that was what I was going to come next.
Pregnancy related, you have to think. Sexual assault, you have to think. You have to think something. Don't
other than
only on coagulation and anovulation.
Absolutely.
Because why a 19-year-old girl will come to you suddenly for the first bout of acute
Yes.
And Mukdha has shown a very beautiful flow chart of how to manage the acute episode. Yeah, Supriya, after you finish, I will invite Mukdha again because this is your domain.
Ma'am, the next thing, will you screen for a coagulation disorder? I think coagulation disorders have been just discussed in the past 2 cases. So definitely, yes, I would like to do her CBC. I would like to do a sugar, fasting and PP, because it may be just something related to, maybe she's a diabetic and associated hormonal imbalance. A thyroid function test is absolutely required. Coagulation profile, we've already spoken about. Is USG needed? Yes, definitely an ultrasound is needed. Because first and foremost, like we already discussed, we would like to rule out whether this is something related to a pregnancy. So whether it's an incomplete abortion, whether it's an ectopic pregnancy, I need an ultrasound for that. There is a possibility that even though she's young, she has some other structural problems, like maybe a fibroid, a polyp. So, or an ovarian cyst, for all you know. And these things definitely we will diagnose on an ultrasound. Something like a polycystic ovarian disease also will be diagnosed on ultrasound. But if she is particularly young, we would be very, very careful while labeling her a PCOD. Unless she's had her menses for at least last 8 years, I would be not very keen on labeling her as a PCO, but definitely that diagnosis will be there in my mind. Differential diagnosis, we've already spoken that first and foremost, pregnancy should be ruled out, or anything related to pregnancy. Drug history is very important, because sometimes if they are on anticoagulants or they are on antidepressant, they can face heavy menstrual flow. Now, how do we manage her? Of course, it will be cause specific. If she is having an incomplete abortion, we would have to do a DNC on her or check curettage. If she's an ectopic pregnancy, put in a scope. If it is related, purely related to hormonal imbalance, then definitely I would like to try the medical management. Now, if we talk about a girl with dizziness, so obviously we are referring to somebody who's come with very heavy bleeding. And these girls usually require high dose estrogen progesterone combinations to start off, to stop the bleeding. Say maybe an oral contraceptive pills 2 to 3 times a day for the first 5 days till the bleeding comes to a halt. And then maybe we will step down the dose to twice a day and then once a day. So we give her OC pills for maybe a total of 20 to 25 days. In addition, I would definitely like to add some fibrinolytics, something like diosmin, which have lesser side effects compared to oral contraceptive pills. So we would definitely prefer those, or maybe even the NSAID group like mephanamic acid, we would prefer in young girls. For long-term therapy, now how long do we treat her? Once we are past the acute episode, at least 3 to 6 months cycles we would like to give her, and observe her over the next 3 to 6 months. If she has alleviation of her symptoms, maybe we can stop the OC pills and see how she proceeds. So the follow-up will be there for 3 to 6 months. And for long-term use, something like a SERM, selective estrogen receptor modulator, also can be tried. Compared to OC pills, the side effects are lesser. Dosage is more convenient because it's not a daily dose. Either you can give twice a week for the initial phase and then switch it to once a week for 3 to 6 cycles, depending on what is the need for that particular girl. So I guess that will more or less cover most of the part.
Mukdha, now your inputs. You have heard how we manage the case of acute HMB.
Yeah, thank you for that, Dr. Supriya. Really nicely covered. So 19 years is kind of on the cusp, isn't it? She's not really an adolescent. She's just entered adulthood. So I think you should keep all the possibilities in mind. And of course, the classification that we talked about, there's a lot of disturbance from the background.
लक्ष्मी मैम, आपका 2 डिवाइसेस साइंड अप है क्या?
नहीं, किसी ने मेरे नाम से लॉगिन किया है, रीनेम नहीं किया खुद को. मेरा फैकल्टी लिंक है. Yes, Mukdha.
Okay, so the various causes that we talked about, the palm point, that is non-gestational AUB. But as Dr. Supriya rightly said, that in this age group, you must keep in mind that there might be a pregnancy-related bleeding. And yeah, I think that's it. I think I agree with most of the things that she's said.
Yeah.
It's very likely at this age for to think about the immature hypothalamic pituitary axis. So if you're thinking of irregular bleeding, it's important to consider the other causes of anovulatory cycles.
Yeah. So now we will move on to the reproductive age group. We have covered the 3 aspects commonly faced during the adolescent phase of life. Now she is a married woman having 1 normal delivery, no history of abortions, and now she has come with irregular cycles and heavy menstrual bleeding. So what are your concerns in the reproductive age group? Yeah, Dr. Divya?
Yeah.
Because the points which have already been covered, you can skip those and just add your inputs. Yeah.
Yeah. Thank you, Dr. Lakshmi, for inviting me at this prestigious webinar. The previous points we have already covered, that we have to know about what is the flow and what is the duration of this this cycle, and also we have to take the history of this pain also. Is the history, this cycle is associated with any pain or not? to rule out the other factors also. So plus, very importantly, we have to rule out the this pregnancy also, because sometimes there is a chances of the incomplete abortions or the retained products of conception. Even though it was almost 3 to 4 months back, she had a history of abortion. Even then, the patient sometimes goes on bleeding irregularly, and they're not able to tell exactly that she was having her missed period in that cycle. Sometimes only 3 to 4 days are missed, and then the patient starts bleeding and having the irregular cycle as having retained products of conception, and she goes on bleeding. And then when you ask for the history, she's not able to tell about it. So this part is very important because she is in reproductive age group. So this part has to be ruled out. Along with that, we have to rule out the chances of the hyperprolactinemia or the hypothyroidism also. Plus, if we have to ask, is there any history of the polycystic ovary also? Because in those cases, the patient have irregular cycles and the heavy menstrual bleeding. So this point has also to be ruled out. So coming to the lab test, all the other tests which have already been mentioned by the other the panelists, CBC and the serum ferritin and so many thyroid and prolactin. These tests has to be done. Plus, we have to do an overall general well-being. We can go for the liver function test and the renal function test also. And we should also take the history to rule out the coagulation disorders. The points have already been covered by Dr. Uma, like bruising, epistaxis, or the gum bleeding, or any family history.
But in this case, it seems very unlikely because she has already undergone one delivery. So I put that point because here coagulation disorders is not our focus.
And the most important thing, here comes the role of the ultrasound, because sometimes the patient might, as I've said, there may be chances of the retained products of the conception. The endometrial polyp, that can be an important cause for the irregular cycles. Sometimes the adenomyoma or adenomyosis. In that case, we have to take the history of the pain also. Plus, sometimes the leiomyoma, especially the submucosal myoma, can be a cause for this irregular cycles, plus heavy menstrual bleeding and other leiomyomas also. So these factors has to be ruled out, and especially we have to rule out the structural causes is there or not, and also we have to look at the endometrial thickness. So once we rule out the ultrasound, by the help of ultrasound, then we have to make the differential diagnosis. So I've already said it might be a case of endometrial polyp, it might be a case of the retained products of the conception, or it might be a case of adenomyoma, leiomyoma, or sometimes the endometrial hyperplasia. So once the diagnosis is made, then we have to manage accordingly to the what is the causes of this patient, and then according. So supposing if the patient is having endometrial polyp, then obviously she has to be treated with the hysteroscopic polypectomy. And if she is having this like endometrial thickness, in that case, we have to take the endometrial biopsy also with the help of Pepple aspirator. So rule out any type of malignancy and what type of hyperplasia is there. And if the patient is having leiomyoma, depending upon the size of the leiomyoma, we have to manage and what is the location of the leiomyoma. Like if the patient is having submucosal leiomyoma, whatever the size is there, she has to be treated. Hysteroscopic myectomy has to be done. But if it is the intramural or the subserosal fibroid, then we have to manage accordingly. And also we have to look what is her desire for pregnancy, for how long she wants to defer the pregnancy. She doesn't to get conceived. That factor is also important, and accordingly we have to decide the protocol. Like if she doesn't want to conceive,
they are very important point, because you have to take a fertility desires into consideration while managing the irregular cycles. Yes, please go ahead.
So like I've told, like if she is having adenomyosis and she doesn't want to get pregnant within 4 or 5 years, then we can also advise her for this LNG IUD, which is a very helpful, especially in the cases of the endometrial hyperplasia. It will also help in adenomyosis. Plus, it may also help in cases of the leiomyoma.
Yes, I invite now Archana. Archana, your expert comments, please.
Thank you, Dr. Lakshmi. Thank you, Dr. Divya. I think you kind of covered the main points. I was writing down things. So yes, fertility, what are her fertility desires is very important for us to know whether she's actually trying for a pregnancy or whether she's, going to give it a bit longer. So that would really, that based on that, we'd be managing. So once when we could start her off on medical line of management without actually doing an ultrasound scan. I know practice is very different here. and in India, because she would probably be just managed the primary care. However, I completely understand where you're coming from. I think it would be difficult not to do an ultrasound in India.
Archana, just to interrupt you, because transvaginal ultrasound we all do by ourselves. So it is just our extended arm. So TVS is being routinely done along with PSPV. So we just can't.
I think that's the issue, isn't it? It's very different from what we do here. In the secondary care, even we do like a one-stop clinic where we actually have this, ultrasound machine with us, and we all scan as well. However, but it's important that some of these patients get managed in the primary care. But again, secondary care, I completely agree with you. We do the same as well. So we would definitely scan her, and depending on what scan findings, offer the same at the same time, offer a hysteroscopy as well. And if like polyp or fibroid, we use the MyoSure, we can at the same sitting she'd be treated as well. And if they do opt for a coil, which again in her case would be very good, especially bearing in mind she's only had one child. So she would probably be planning another pregnancy. Very rare not to have another one. So I think that's
she would definitely want. So now we have covered the reproductive age. Let us come to the perimenopausal and menopausal aspect, because here the scenario is different. So Shailaja, this is a 45-year-old lady. She has 2 normal delivery, no abortions. TL has been done. I mean, tubectomy, no comorbidities. Now at this age, how you will go about the irregular cycle and heavy menstrual bleeding?
First of all, I would like to thank Lakshmi ma'am for giving me this opportunity. I would like to take a detailed history of her menstrual cycle as for now, what is happening actually, since how long is she having this abnormal bleeding, and how severe it is. First assess that, and then I would like to ask about the associated symptoms, like whether it is associated with pain or not, any other pressure symptoms or any contact bleeding, and intermenstrual spotting. And then I would like to ask about the symptoms of any hypothyroidism, and since she's in the perimenopausal age group, maybe symptoms related to the transition, like hot flushes and mood swings and sleep disturbances. And if you take the past history, I would like to know whether this anovulatory cycles were actually even in her reproductive age group, like even in before that, whether she has really regular periods, or even then she has any chronic anovulation, and whether she had any early menarche, and then whether she had any ovulation induction drugs for conception, she had any difficulty in conceiving, all that history also I would like to take. And then personal history, like maybe is she diabetic, or you said there are no comorbidities, but still I would like to ask her whether she's a diabetic or not. And then any of these drugs like the anticoagulants, and some people nowadays they're using these statins and antiplatelets prophylactically also, and any of the progesterones that are being used irregularly for the symptoms, suppression of these symptoms, and antidepressants and antipsychotics, all these and even some Ayurvedic preparations which has this ginseng, which is being used quite often by practitioners. This also leads to an abnormal bleeding. So I would like to ask about all that, and especially the family history about the endometrial carcinomas, and then breast cancer, ovarian cancer, and colorectal cancers. I would like to ask, and then have a detailed examination of the patient, especially focusing on the structural abnormalities, because the structural abnormalities are more common in this age group, and that is look for any malignancies or ulcers or growths in the cervix, and then a polyp projecting a prolapsed polyp or vaginal growths, and then do a pelvic examination for the size and the shape of the uterus and any adnexal masses. And then a lab test, first of all, because she's
Can I just interrupt you, because you mentioned very, very relevant points here, because especially in this COVID and post-COVID era, many of our women, they had taken a lot of kadhas, those cocktails and mocktails, and I mean, nothing against any pathy, but the homemade a lot of things they have taken. So you have brought out that very important point to ask that history. And second, you have rightly said that now from coagulation, we have to move towards the carcinoma, I mean, the history of cancers. So these are two very relevant points which you have mentioned in your history taking. Yeah, please go ahead.
And with lab tests, to see the hemoglobin status and all, I would like to have a complete blood picture, then rule out blood diabetes by doing the oral GTT, and then a thyroid function test, that is a TSH, and perimenopausal. So let me have a FSH also, and prolactin levels, and maybe though she's tubectomized, maybe I have to rule out any pregnancy events also. So I want to have a HCG. And if at all there are any adnexal masses, I would like to go for any tumor markers as well.
Shailaja, if her endometrial thickness is 12 millimeter on day 5, will you
Yes,
advise her endometrial biopsy? How, when, what is the role of hysteroscopy?
12 millimeters more, yeah, yes, ma'am. If
On
it
day
is
5,
more than
on day 5 and
more
TSH.
than 12 millimeters, I would like to go for a actually more than 20 millimeters, I would like to go for a endometrial biopsy. But because she's a case with, she has this abnormal bleeding recently, so I would like to rule out the endometrial carcinoma. So it is better when she comes, it is better to take a endometrial sampling with the OP sampling methods.
Yeah, if you are finished, I would like to call upon Archana for your inputs, because I really want to know the role of endometrial biopsy, the blind versus the see and take a biopsy. So how you practice in your UK, whether all biopsies are hysteroscopy guided or you do take endometrial biopsy like we take by people and all.
We tend to do most hysteroscopy guided, because we have in our men's
ideal, yeah.
We have hysteroscopes at the same time, and the 3 millimeter scope, especially with the vaginoscopic approach, it's very straightforward. Patients tolerate it really well, and then we just take a biopsy at the same time as well. However, it is practice where we do take blind prepare samples. Again, this lady, we would definitely take a biopsy. 45, she fits the age group, and again look at the other risk factors, and we would ideally want to take a hysteroscopic guided biopsy. But because hysteroscopy at the same time would rule out other causes.
You can take, it can be because of polyp. Yeah, because on day 5, if it is 12 millimeter, I would definitely like to put a hysteroscope and take the guided biopsy, or if there is a polyp, to remove the polyp.
Yeah, see and treat, we can do a lot of this. And then if she wants the same time, she would want to have an ablation or something, we tend to do it at the same time. Take a biopsy, cavity looks okay, you're not thinking in terms of hyperplasia or cancer, we do an ablation at the same time as well sometimes.
At this age group, do we advise ablation, follow up with if at all there is any hyperplasia or anything?
You rule out malignancy, then only you can go ahead and do ablation, whether by hot thing or TCRE or whatever. But you have to be 100% sure that malignancy is ruled out. You just can't do it. But if you have taken endometrial biopsy, and now WHO has come out with a very simple classification of the endometrial hyperplasia.
Yes,
so, Shailaja, how you will manage if it is with urticemia, or if you get the biopsy as without urticemia? Because we don't say now cystic hyperplasia or glandular hyperplasia, those are obsolete terms. So just tell us, the audience, in case if it is hyperplasia with urticemia, and another scenario is hyperplasia without urticemia.
Yeah, with hyperplasia without atypia, the progression of this one is less than 10% in when it is to an endometrial carcinoma, when it is followed for a 20-year period. So it is better we go for the medical management, and first, if at all the patient does not have any risk factors for endometrial carcinoma, and if at all there is any obvious cause that is actually the source of the estrogen that is giving, and we could remove that, then we may go for an expectant management, provided the patient has to be under follow-up, and otherwise we have to start them on the progesterones, the medical management. The best thing is to go for the LNG-IUS, which is better than the continuous
cost has also been reduced now with
management.
multiple
Yes,
companies coming out with the LNG. Yes.
Yes, ma'am. This will have a better, the regression rate is also more, and the relapse rate is also better. I mean, there's no low relapse rate, and we have these patients had to be, in spite of it being an atypia, these patients had to be followed, and they should be coming to every 3 or 6 months. They have to be followed for a period of 1 year,
Poison
at least 6 months.
Yeah.
At least once in 6 months, and then each time they come, we have to do an endometrial sampling, and then see if the picture of the pathology, whether it is going into the normal. If it is really we can see a normal endometrium, and if it is seen for the two consecutive samples that are taken 6 months apart, then we can actually say that there is a regression, and we can ask her to come again if at all she has any bleeding after that. Then if it is if this pathology like the atypia without atypia persists, then we may go for if she's not on any LNG, if she does not take any LNG, or if she's on expectant management, we can ask her to go for the LNG, or increase the dose of the oral progesterones which have been given, or if otherwise you go for an permanent, that is a definitive management like a hysterectomy, if at all patient is not willing for follow-up.
Yes.
And then if there is if this progresses to atypia, surely I'll go for an hysterectomy, and hysterectomy with salpingectomy.
Yes, I was going to ask you that is salpingectomy versus salpingo-oophorectomy.
Yeah, I actually, if there is any atypia, history of atypia, I mean, the pathology shows that there is atypia, then maybe we have to do an salpingo-oophorectomy of because she's a woman of 45 years. That's what I think.
Yeah, now I will invite Archana, your take on management of endometrial hyperplasia with atypia and without atypia, how you manage.
Yeah, so similar, I think I do agree with Dr. Shailaja. If there is no atypia, then you put them on progesterones, make sure you get samples, 2 samples, 6 months duration, 6 months apart. So you've got one, put it on progesterone, either oral or coil. Again, Mirena coil, LNG-IUS is what we tend to offer. Some people don't agree with that, then oral progesterone. Take a sample in 6 months' time. Then again, similarly repeat, 2 samples negative, kind of discharge. Again, look at the risk factors to see if she's high risk and discuss if she would want any further treatment, and that would be more permanent like a hysterectomy. Again, with atypia, definitely offer more definitive management hysterectomy, total laparoscopic hysterectomy.
But salpingectomy versus salpingo-oophorectomy, where you will do?
Salpingo-oophorectomy, definitely after counseling patient with atypia, and without atypia, we don't tend to do hysterectomies. If only patient choice, they want to say, oh no, we don't want anything in either of that, I want a hysterectomy then, but otherwise definitely not hysterectomy for without atypia.
Do you routinely combine salpingectomy with hysterectomy?
Yes, all hysterectomies we do salpingectomies.
Can you tell the benefit to our participants of removing the tubes only along with the uterus and keeping the ovaries?
Sure. So basically, the origin of ovarian cancers also has been attributed to coming from the fallopian tubes. So if you're doing a hysterectomy, no point leaving the tubes behind, because there is the theory that ovarian cancers can arise. So we do tend to do bilateral salpingectomy along with all hysterectomy, so that the risk of ovarian cancer is reduced. And so that's the main reasoning behind that. And so all patients we do salpingectomies.
Yeah, this is the changing trend. So this is the good take-home message for all the participants. You keep ovaries, but you remove the tubes along with the uterus. And friends, many women at 45 years, either without atypia or with atypia, they do want a pregnancy, because I practice infertility. So more and more women, they are coming to us for the fertility treatment at this age. So please refer them to a fertility specialist. because the management entirely differs if she wants a baby at this age with the complaint of heavy menstrual bleeding. So now let us come to Maninder, who is expert. Maninder, now this is a post-menopausal bleeding. She is 60-year-old, known case of diabetes, hypertension. She has completed family post-menopausal 10 years. She has come to you with 2 bouts of bleeding in last 3 months. This is our last case. So your take home on management of this case. Maninder?
Thank you, Dr. Lakshmi. I went back 4 or 5 decades when during my MBBS final year examination, Dr. Das from Delhi had come and she asked me, what is the cause of post-menopausal bleeding? And as usual, started and faltered and started from uterus. She looked at me, stared me, and I corrected myself because otherwise she would have failed me. She said, start from the very beginning. So you have to start from the lower end and here never in the top end, because that is what we think a post-menopausal bleeding, uterine cancer.
Excellent, very good.
So just 10% causes, rest of the causes are not malignancy at all. So always start from below. As far as the history is concerned, I think we can ask history of PCOD because she's already diabetes and hypertensive. But very, very important, any history of previous coagulopathies. Secondly, is she on any drugs because she's hypertensive? Hypertension, diabetes mellitus, might be she's taking anticoagulants, as already has been mentioned by the previous speakers. Family history of cancers or your own history of breast cancer, because they will forget, even you will forget whether she is on tamoxifen or not, whether she had other cancers treated, whether in her family there's a familial history of colorectal cancer, breast cancer or ovarian cancers. These are the very, very important points which we should be looking into the history. So then we come to her complaints. We will be asking her whether she's having bleeding related to defecation, related to urinary problem, or is there a burning there, or it's related to intercourse because they can be still active sexually, or whether she had some cognitive impairment and she fell down and she can't tell you. So bleeding can be a local trauma. Can the sexual abuse be there in these women? As in all your previous cases you mentioned, yes, sexual abuse can be there. And it's big cause.
Fantastic. Because even traumatic intercourse in the marriage also can lead to the bouts of bleeding.
Yes. So that is there. Then you get to the urethral problem, whether she's having in burning in maturation or not. So all these are, whether she had a pessary inserted, she forgot about it. She had the IUD inserted, she forgot about it. When she had her last pap smear, has she had ever once in a lifetime even? So all these are important issues which we should be asking her. I think I have completed the history because
yes, fantastic, you have covered.
Oh. Now we go to her examination. Now, why did I ask her bleeding from the local? So what type of bleeding she has? How heavy bleeding or a slight spotting only? Or she's just looked at her underwear and found that they were stained. This is very important. And here you have told me that she has 2 bouts of bleeding. So important because this is just not one bout. There have been 2 bouts of bleeding which are important. So when you start examining her, you look at her, not her height, weight, BMI, which is very important because obesity is one of the causes of the hyperestrogenism and causing hyperplasia, because androgens, they get converted into the peripheral adipose tissues to estrogens, even in post-menopausal women. Very history important here, because I saw 3 cases lately. It's not the menopause hormone therapy, whether she was taking or not. That's very important, because if it was an imbalanced, progesterone was not completely covering the estrogenic effect, then she can again have estrogen. But was she having local estrogen preparations? We think local estrogen preparations are not causing endometrial hyperplasia. But recently I have seen, because I just could not find anything in them, and I have endometrial hyperplasia of 12, 14, 16 mm in these women. One of them gave me using Primarine cream. But for how long she used, she could not remember.
Yes, because in India, they abuse our prescription, Maninder. Once
They are
you write
not
one
giving
tube
the
and they just
prescription
go on
record.
taking it for years.
Yes. So that is where I want a role of AI, artificial intelligence, to come and have the electronic records of all the patients, so that at the end of her life, we just don't have to go through those hundreds of prescriptions and
No,
find
Maninder,
out.
the another is that we all should prepare a stamp that this prescription is valid till this date. I think I always recommend in all the webinars that in India, we really need it, because our patients, they go on taking those drugs for longer period of time. So once we write it is valid till, the pharmacist will not give, na. I mean, if she goes to a pharmacy, but everything is OTC in India. Yes, everything is available over the counter. Yeah.
So anyway, they are not giving on our prescription. So when you start examining, please look at into the local vulva, because might be she's having a complete sclerosis, lichen sclerosis. And I have seen lately case where she was starting typically from the clitoris to the perianal region, labia majora, minora. She was eating. So these patients, they go on eating and sometimes can bleed from there. And might be she has been having, somebody has prescribing them local estrogens or something along with progesterone and everything. So look into them, and there might be a cancer area also hidden there. Please don't omit those cancer. Then go into the vagina now. Now you go into the vagina, you find the vagina is atrophic. You find there are particular hemorrhages are there. I have seen my own auntie coming to me with post-menopausal bleeding. I was scared. Oh my God. So that is the first reaction you have. But when I looked into it, she had a local atrophic vaginitis, and all I had to give her was Metrogyl and for a shorter period only estrogen. Now with estrogen, because we were advising for 1 year, we don't need follow-up. But now I have changed my opinion, because if the patient is in later years, especially beyond the age of 55 years or so, the vagina becomes so atrophic that absorption of the estrogens is more there from that atrophic vagina. So that's why perhaps after 3 months, we should be examining these patients at whether they have not had the endometrial hyperplasia, because looking after these 3 cases, I have changed my line of practice now at least. So then, of course, you go up and look at the cervix. And if had not been done LABC and everything, you have to do with a brush only. And after that, we come to the very, very important part, that is the transvaginal sonography. So this is the basic which you can do within 5 minutes when the patient comes to you. The only thing is, should be at your tips only. So you have taken the drug history, you have taken the local, you have taken the sexual, everything we have taken into. Now we do the ultrasonography. Now here comes the, how thick is the endometrium, which is risky. So that is very, how thin, how thick. So how thin? Normal, the guidelines say, okay, if the patient is not taking HRT, 4 mm. Patient is taking HRT, 5 mm. Patient is on tamoxifen, 6 to 7 mm. But do they always matter? No. You have to look into the echo texture of the endometrium also. You have to see whether the interface between the endometrium and the myometrium is maintained or not. If there is a focal thickening or not. If it's a uniform thickening. If it has been a repeated bleeding. Even with the thin endometrium, go and do the people aspiration. If the bleeding continues after people aspiration, you don't get anything, then you go for hysteroscopy. Go for hysteroscopy, look at the complete endometrium, and then do your focused biopsy. When you are doing ultrasound, look into the adnexa, very, very important. Fimbrial, fallopian tube carcinoma, ovarian carcinoma, breast carcinoma, they can all have their secondaries here. So don't forget, along with the familial cancer. So you have done your ultrasound, you have done it. Now, what are the challenges in the menopause? The woman is so atrophic, she won't let you even touch her. How are you going to look at her? That is the time, perhaps, you should be using a local xylocaine ointment. It doesn't harm her. You can use it, clean it, she's anesthetized, then try to use with the smallest speculum possible if it is possible. Then hysteroscopy also, I don't think any one of them is going to let you do under local anesthesia. You will have to do under general anesthesia only. So these are the challenges. Sometimes you cannot even introduce a hysteroscope or anything, even people. Then what do? They have suggested perhaps you should go through the uterus and take the sampling. Or better, in these 60 years, should we be going for hysterectomy then? Rather than calling them again and again and doing all sorts of investigations and putting them under so much of stress. Even Dr. Archana and Mukdha would like to go, because these are the cases, they are justified, because we are not worried about ovaries now. So we are not worried about their supply. We are not worried about their estrogen symptoms. We are worried about the thing, bleeding, which is there, where we are not able to find out the source. So that is one thing. Another question, what are other questions? Lab investigations. Yeah, you have asked me for coagulation disorders. Yes, like I said, if the patients have been forgotten, we have not taken them, we should be taken. They are already on anticoagulation, so we should be taking them. Role of ultrasonography we have done. Endometrial biopsy we have done. Differential diagnosis we have discussed, because we go from below upwards, and how will you manage her? So that was the last question which I was coming up. Sometimes, really, in our scenario, we can have tuberculosis also. So don't forget them. So whenever you are testing them, do test them. So how do you manage them? You go from below, whatever the reason you find. Should I go be elaborating treatment for everything? I think that is out of context here. The only thing is that you should be diagnosing them properly. Never go and think that it is an endometrial carcinoma, so remove all the uteruses. Perhaps we have to save those 90% of the surgeries, do in 10% of the cases where it is required or where we cannot help them. And lab testing, of course, we have to do liver function test, TSH, very important. Kidney function test is very, very important in these cases. And then MRI, if we have to see the extent of the disease. CT scan doesn't have a role to play unless we are finding that there are secondaries everywhere in the body which we have to look into. Follow.
Yeah.
Tell them it is your body. You have to look it up. And till the time you die, you have to be active, remain active, and be independent. That is very, very important. Please make all the midlife women independent, because we are passing through a very, very bad time at this time. The children, especially our daughter-in-laws, everybody is working. Nobody has time for their elderly. If they get some time for their kids also, that is sufficient, I think. And we should not expect that they can look after us. So look after yourself. So whatever the cause of the bleeding from adolescent to menopause, never forget the exercise, never forget the weight management part. That is the basic reason for so many of our problems, and positive attitude. That is very, very important. Diagnose and get over it. Whatever it is there in the life, you will be getting. But please move on. I think, Lakshmi, I've covered everything.
Yeah, Maninder, fantastically, you have covered everything. Now I invite Archana for her inputs on the case of postmenopausal bleeding. Yes, Archana.
Thank you, Dr. Maninder. Very concisely covered all the aspects from down below, going down from down to up. Yes, we all worry about endometrial cancer, and it's only 10%, like you've already stated. I think main differences I'll just cover from practice-wise here, which is different, is you said outpatient hysteroscopy is not something you can do, but however, our mainstay is outpatient. I think personally, about 85% of our postmenopausal women actually are okay with outpatient hysteroscopy. We do a vaginoscopic approach and put a small scope in. I understand it can be different setup of practice. But yes, I completely understand that. But this is what we tend to do here. Definitely hysteroscopy. We don't do blind biopsy in postmenopausal women. It has to be hysteroscopically guided. And yeah, that's the main thing. Our cutoff is 4 millimeters. Some four above 4, some 4 included. So that's what we do. And one thing I would want to say is 6 months is what we reassure our patients, saying that if you have any further bleeding in the next 6 months, that's fine, don't worry about it. However, if any further episode, then we do tend to call them back to evaluate to see if if any different, measure the endometrial thickness again. And like you mentioned, it's just not the endometrial thickness, looking at different aspects of the endometrial lining and the echogenicity, and all of that has to be taken into account as well.
It's not, I'm not against OPT treatment. I am there, but I said the challenges are there. Challenges are there when the stenosis is there. And sometimes these cervixes are very stenosed. Sometimes these vaginas, they are so tender to touch, and because they have not had an intercourse also for years together, so it's very difficult. So those are the challenging situations, I said. So of course, follow-up, one thing which I want to highlight is, sometimes follow-up can be late in these cases. Follow-up is very, very much required in these cases. Because whatever turns out to be one episode of bleeding in one of the neighbors, she missed out that one episode of post-menopausal bleeding. She did not even consult me. And later on, when she had a secondaries of the ovarian cancer, that was the ovarian cancer which was bleeding then, she has 3rd stage ovarian cancer. At that time, she was diagnosed. Yeah, one of the symptoms which I had missed was if the patient is having belching, or the digestive system, that should not be missed out, because that is where ovarian cancer is very difficult to diagnose. But when we start looking into these things then intensively, that is where we won't miss out. Thank you.
Very well said, Maninder. Yes. Yes, Archana, you want to add anything?
No, I'm okay. Thank you.
Yeah, because we tried to cover all the important aspects of the abnormal uterine bleeding, right from coagulation disorders to anovulation, to acute management of acute HMB, to reproductive causes, to endometrial hyperplasia, to postmenopausal bleeding. So this was the whole gamut we tried to cover in this focused webinar on abnormal uterine bleeding. And I invite Archana for her closing remarks, and then Sushma to propose vote of thanks. Archana, you would like to say anything? Yeah.
Thank you, Dr. Lakshmi. It's thoroughly, very, good experience where we've got to hear from your side, and we've told us our, how we manage things as well. And definitely, we've covered the whole reproductive age group, and the adolescent group, and the postmenopausal. So anybody who's attended the webinar should be an expert at managing abnormal uterine bleeding now. And I think it's very systematically done as well, so people remember and put it into clinical practice. So thank you very much. And thank you, rest of the panelists. You've all been, very good, and the knowledge is extensive, I can see. So thank you very much for your time.
Yeah, thank you so much, Archana. Yes, Ajay. Most welcome.
I just wanted to ask Archana Madam that due to that NHS, the treatment is delayed for your patients, appointments is given after 2-3. Can I just delay in taking appointments and getting the treatment very late?
Sorry, you were not very clear. Are you asking about the present?
Your voice is breaking, Ajay.
Okay. In England, you are having one NHS system, no?
Yes.
The patient is referred and the appointment is taken. The appointment is given very late, I heard. Is it true?
Very variable. It's very variable. Yes, COVID has affected NHS, and there is a delay at the minute. But again, if any patient is a red flag symptom where the, like postmenopausal bleeding, they will be seen within 2 weeks. And now most of the trusts are actually working for a target of 1 week. So we tend to see any patient with suspected cancer within 1 week, and diagnosis is made fairly quickly as well. However, for normal menstrual problems, there is definitely a delay. But the primary port of contact is a general practitioner who tends to see them within a week or 2. So first line of treatment, like medical line of management, is started. Being referred to the secondary care, there is a bit of delay. Again, there is the private sector if patients want to see if they have health insurance and things like that. So it is a combination of things, yes.
Yeah, Mukdha,
Yeah,
there
yeah.
is one question for you, if you can take that in the Q&A section. Just one last question we will take. Can you read it, or I should read it for you? Mukdha, unmute yourself.
No, I can't see it. Where do I
Yeah,
see
one
it?
19-year-old girl came with prolonged bleeding of, it is in Q&A. The prolonged bleeding of 20 days with no relief after Trenexa. This is her 5th episode in last 1 year. History of CVT after progesterone a year back and craniotomy was done. So what is your input for this girl? She developed, yeah.
I would like to know more.
So she developed CVT with the use of progesterone.
Progesterone. And she is 19 years. She has prolonged bleeding of 20 days with no relief after Trenexa.
Might be she had other coagulopathies.
Yeah, must be. Because,
It's important to understand the baseline cause
Yeah.
for the bleeding. I mean, to get to the bottom of what the bleeding is. Management is going to be a bit challenging for her case, because if she's had a history of CVT, then it's going to limit our options for treatment for the long term. But I mean, she's 19. She may be a good candidate for maybe a Mirena coil, if that's what I feel.
Yeah.
Because
but in India, I mean, at 19-year-old is a really problem. LNG. For unmarried girls, it's really a problem.
Yeah, I mean, it's important to understand whether she's got a bleeding disorder, because then she could be managed better through the hematology team.
Yeah.
If we are able to understand. But hormonal management is going to be a challenge in her case.
Yes, definitely.
You can probably try diosmin, or maybe the selective estrogen receptor modulators, which might not have these coagulopathy as a
Archana,
side
you
effect.
use SERMs in UK? Selective?
Yeah, we do use, but not very commonly.
Because in India, we use commonly.
Not a first line, I'd say, definitely. A mainstay is hormonal contraceptive pills, and then coil. Coil is used as a first line,
in
left,
your
right, and center. And because we have family planning clinics as well, so they're walk-in clinics. So sometimes the GPs just advise them to have it put in there as well. And again, in a younger group as well, patients don't mind having a coil. Even nulliparous women.
Yeah, in UK, but in India, married women, they do accept LNG, but for unmarried, even if she is 25 years of age, I mean, it's really challenging for us as a doctor to say anything or write on the file that she is sexually active. So that is the problem for us.
Oh no, here it's like
yeah, I know.
Very different on that aspect, yes.
Yeah, so Sushma, floor is all yours.
Thank you, ma'am. Thank you very much. Thanks a lot, our esteemed faculties, for wonderful lecture and panel discussion. For me, it's a great pleasure to be a part of this wonderful webinar and with its senior and eminent faculties. It has been a wonderful journey packed with knowledge, and the whole credit goes to our esteemed faculty members. On behalf of team of Indo International Web Series in association with RCOG License Group, I would like to extend my sincere thanks to Dr. Lakshmi Srikhande ma'am and Dr. Josna Pundir ma'am for putting lots of efforts in organizing this wonderful webinar on AUB with such esteemed faculties. I would like to extend my sincere gratitude to Archana Hattin ma'am from UK for taking out time from her busy schedule and for elaborate lecture on AUB. From the bottom of my heart, I would like to thank Dr. Mukdha Kulkarni ma'am for her elaborate talk on evidence-based management of adolescent AUB. And then I would like to thank our eminent moderators for the panel, Dr. Lakshmi Srikhande ma'am, and our experts, Dr. Archana Hattin ma'am and Mukdha Kulkarni ma'am, for giving deep insight on the topic. I would like to thank our senior esteemed panelists, Dr. Maninder Ahuja ma'am, Dr. Uma Pandey ma'am, Dr. Richa Sharma ma'am, Dr. Divya Agrawal ma'am, Dr. Shailja Pinjala ma'am, and Dr. Supriya Arvari ma'am for sharing the knowledge and making the panel discussion very interesting. I would like to thank our chairperson, Dr. Supriya Jaiswal ma'am, Dr. Vijayalakshmi Sheshadri ma'am, and Dr. Ajay Mane sir, and Dr. Mala Srivastava ma'am for chairing the session and sharing the interesting facts. And at last, but not the least, I extend my sincere thanks to Dr. Jyoti Malik ma'am for conducting the webinar so well. And lastly, from the bottom of my heart, I thank Dr. Lakshmi Shikhande ma'am and Dr. Josna Pundi ma'am once again for their vision and putting enormous efforts in making this webinar a successful one and giving me the opportunity to be a part of such esteemed webinar and giving me a wonderful platform. Thank you very much, ma'am.
Thank you, dear Archana. I hope it was a good experience for you. Mukdha, did you enjoy?
Thank you.
But we really learned a lot. Both of you covered practically speaking all the aspects, and I just panel discussion was just a revision class for all the participants.
Yes, ma'am. It was very wonderful, ma'am.
It was amazing, and it was so well organized. Really enjoyed
the flow charts and all is real. I mean, they were really wonderful. So thank you so much, Archana.
Lastly, ma'am, thank you.
Yeah, and Rukna Ranjit, and thank you, Walter Bushnell, for providing the technical support.
Thank you, ma'am. Thank you for giving an opportunity for a in-length discussion with AUB, ma'am. It was wonderful to be getting connected, and Walter Bushnell always stands committed for the such kind of scientific piece, ma'am. We love to be get associated. Thank you all.
Thank you.
Have a lovely evening, ma'am. Thank you.
Thank you. Thank you, Lakshmi madam. Thank you very much.
Bye. Thank you, sir.